Om Saraswati Bhavatya Pranamaya Namaha Vishnu Bharatya Pranamaya Namaha Bhasma Pranam Suruye Namaha.
Dr. Mangal, you have loaded yours. No, have you loaded yours? Because you can start that. Where is Dr. Rahul? It's loaded? Yeah, please come and start there. Good morning, everybody, and welcome. I'm sorry that we are starting a bit late, but we'll ask Dr. Divya to make her presentation, and meanwhile, Dr. Rachate and Dr. Kuntal Kantidas will get their presentations ready. Start, please. It has actually been a very remarkable, and I personally thank Dr. Srinivasan for the teaching which he did yesterday. It is actually something which is, I would like to include this into the workshop, because this type of teaching which you did, I really wish a lot of our people from Tamil Nadu and from Chennai would have had the, insight to appreciate that this learning is not easy. As both of us know, that approach probably requires the, pinnacle of neurosurgical precision, because an odontoid screw, if it is placed this way or that way, can cause instantaneous death on the table to the patients. Saying that, overall, all the patients which were operated, they are doing very well, and each of these workshops adds to our learning. It adds to our learning, and probably, because I have seen a lot of workshops, this is a very, very important part of our growth. So personally, we have grown. Thank you for thank you.
So transpedicular approach to anterior and anterolateral pathology. So the burden of metastatic spinal cord compression is greatly increasing. So this is how we can all approach laminectomy, transpedicular, costotransversectomy, and lateral extracorporeal approach for the discs, tumors, kyphotic correction, and for fracture stabilizations. So initially it was described by Patterson and Alwarpet in 1978. So we do a unilateral exposure, and once we reach the thoracodorsal fascia, subperiosteal dissection, drilling of thoracic pedicle 1 to 2 millimeter beneath the inferior facet of the superior vertebra, after which laminotomy is done, and drilling of the supramedial pedicle, and then we can insert our screws. These are the other the various patients that we have done via transpedicular approach. This is another lytic lesion, metastasis of D1. So these are the three approaches we normally use, and we have a various series of patients which we've been doing. So this is how we mark via C-arm. Also run for aneurysmal bone cysts for stabilization. And this is another introp picture. So C-arm is used for localization of the dorsal spine. We were using this 3D digital C-arm previously, and now we have neuro navigation. So this will be our future. The main problems were the narrow corridors, limited trajectory, inadequate decompression, and injury to the neural structures and adjacent structures, instability. So the per-operative complications were wrong level of surgery and localization, and tackling hemorrhage. So the main problems were the narrow corridors, limited trajectory, inadequate decompression, and injury to the neural structures and adjacent structures, instability. So the per-operative complications were wrong level of surgery and localization, and tackling hemorrhage. So Complications were significant blood loss, years of leak, wound adhesions, and residual paralysis, mostly in dorsal. So concluding that posterior unilateral or bilateral approach via pedicle combined with quadrilaminectomy or hemilaminectomy can give a good access for decompression, histopathological confirmation, and stabilization if indicated. The thoracic spine is the commonest site for metastatic secondaries, and these are increasingly being referred for decompression with good outcomes. Thank you.
Yesterday night, sir, will place it. Please place it there. Okay, are we ready? Yes, sir.
Implant failure in neurosurgery. Next agla.
That's okay. I don't have anything to do. I cannot have this obstruction. This is important. You can put it to the side of the speaker and face the speaker this side.
Implant failure in neurosurgery, complication avoidance and its management. The use of implants in spinal surgery is increasing due to the increasing number of spinal trauma. The radicality of excision is a better understanding of the spine biomechanics. The objective is to emphasize the various complications of spinal instrumentation and measures to avoid them. The youngest patient was 4 years old and oldest was 83 years old. Implant failure was most commonly seen in the cervical region. Implant failure was seen in 13 patients. Screw pull-out in 7, broken plate in 1 and sinus in 2. All patients were investigated with X-ray. And all patients routinely X-ray was done post-operatively, and if any other problem was there, then we got it SOS. So CT scan was done in a few cases. We also did MRI. So despite the locking screw being in position, one screw had migrated out. Occipitocervical fusion, screw pull-out, redone with wires and screw, and the screws again have partial pull-out. The anterolateral system, it provided a single-stage cord decompression and a short segment stabilization. The screw position is difficult to ascertain on plain X-rays. The screw can encroach the canal. So resurgery was done in 56%, implant removal in 7%, and conservative management in 7%. So the implant failure necessitates the removal of the plate, and despite fusion at that level, restabilization has to be done, and as there was dislocation at a lower level. There was a minor screw pull-out, which was managed conservatively with periodic follow-up. And the significant screw pull-out, which the removal of screw and the implant, and fusion has already occurred. This patient was managed conservatively as there was a good fusion. This is the problem with the plate. The strength of the plate and the design is faulty. It has bended over. Implant failure is persistent in tuberculous cases and pediatric cases more. Inappropriate size of the plate and inappropriate contouring is one reason for implant failure. Pre-contoured plates help us in tackling this problem. So the familiarity and availability of the appropriate hardware is necessary to get to tackle the implant failure, and it should be always available sterile during the case. Contoured self-locking plates. So we need to have a complete range and sizes available, or else a longer or a smaller or any adjustment done can lead to again failure. These are the screws. The tapping screws will give less number of circumferential turns, which will help in less purchase. So implant failure avoidance, which have a recent X-ray immediately. So the bone quality is poor at level, and we may force to use a longer plate. So you use always plates with some screws, self-locking and self-locking screws. Short segment transpedicular instrumentation of thoracolumbar burst fractures, it is associated with high rate of failure that cannot be decreased by adding a transpedicular intracorporeal grafting. So single trajectory for decompression and fusion, short segment fusion is possible. All deteriorations are not due to implant failure alone. Post-operatively, in this patient, the patient had a cold abscess which causes deterioration, but implant was in place. So the implant failure because of poor bone quality, osteoporosis and tubercular osteitis is also one reason. If the implant is too long, it will have a crankshaft effect, especially if there is poor bone quality due to osteoporosis and tubercular osteitis. Triangulation and perfect position with the pedicle is necessary to avoid the implant failure. Avoid screws less than 16 mm self-drilling screws, as they have 2 mm less purchase. And always midline has to be respected so that we are able to get the graft perfectly. Standalone cases will automatically have the tendency to fail. So along with that, we may use contoured plates. But in this patient, the plate is too long and the screws are too thin. So result of the analysis of hardware failures may be used as a basis for refining surgical technique and designing the next generation of implants. Use of microscope during the placement of implant and when it is required to be removed. Use of microscope during placement of implant allows for high cervical, low cervical approaches with the self-current locking plates and self-drilling screws. In the anterior cervical region, the upper screws have the tendency to pull out. And in the lumbar spine, the lower pedicular screws have a tendency to fail. In appropriate implant, all the fusion has occurred. And this patient with dysphagia and the implant is being pushed away with the progressive deformity. Better instrumentation with low profile plate locking screws, better materials, usability, appropriate choice of patients, indications and smaller fusion segments with evolving neurosurgical spine technique have reduced the incidence of implant failure. Thank you. Next.
Next, you want to present? This presentation was supposed to be done yesterday, but because the cases were long, so this has been done there. It's a very, very important aspect of, this is why this time we wanted the IIT engineers to be part of this, because this is a continuous designing problem which we have to keep on evolving. As our techniques evolve, the technology has to evolve also. As exemplified with the odontoid screw, because now we have Indian screws. Earlier on we used to have the cannulated screws which were available from Medtronics only, and then we were dependent on that system, and that system sometimes was parked at CMC Vellore, so we had to wait for that system to come. Then we would have had the navigated thing with the screws. Even that, in those screws, what was the problem is those screws were designed for the American population and for the Europeans, and the screw length, we were having, we wanted a precise length because the Indian odontoids are smaller, so we were not able to have that. Because the concept of putting two screws into the odontoid, I really do not understand, because if you remember the first one slide which I showed, a CT scan showing you the odontoid, it is literally fitting so much, it is nearly the same size. So instrumentation has to be designed as per the local population. And probably you need, because all spectrum of population is there. So this is a very, very important part of learning. And that's why this is workshop is again a first, because it introduces this concept of having the workshop attended by other specialities so that neurosurgery can progress even further. So I will ask Dr. Mangal to finish his presentation so that we do not waste time and we are in phase. He was supposed to speak last, but he will be there. The other speakers will be there. They are held up in traffic, so they will be here soon.
Yes, sir. 3D printed titanium mesh calvaryal reconstruction. So, cranioplasty remains one of the most commonly performed neurosurgical procedures, and James T. Goodrich once said that all the cranioplasties eventually fail. Autologous bone, it is perfect in contouring, but it is a dead bone, so has problems of reabsorption and storage. According to study, it was 8% was infection and 16% bone reabsorption. Another is osteomyelitis, empyema. These are complications in which patient needed 2 more surgeries, and along with that he had to bear the cost. So almost 20% of the bone lost after 3 months. And post-operative bone resorption occurred in 44% cases. So bone resorption continued in this patient beyond 12 months after autologous cranioplasty. There was another complication is SICH. It was in 13.8%. And the post-operative hematoma which required evacuation was in 2.3%. So the benefit with using titanium mesh 3D implant is it is porous in nature, and this will prevent all the extradural collections. So use of primary titanium cranioplasty after decompressive craniectomy reduced the number of reoperations needed and associated long-term hospital cost. So autograft versus 3D printed titanium cranioplasty. In such cases where the bone loss is maximum, complex reconstruction is needed. So that is not possible with the autologous bone. So the 3D printed titanium mesh cranioplasty is beneficial here. The perfect restoration of the skull morphology is difficult to attain. And from split calvarial autografts, rib cranioplasty, tantalum, steel, acrylic, the materials used are all deficient in their usability. Even 3D printed flaps may not be perfect fit and allow for temporalis wasting defect. In this patient, we are able to see here the defect despite covering. But in this patient, the temporal defect is very well covered. The syndrome of Trephind is a difficult problem that necessitates an early flap replacement. Neurosurgery has a long experience with titanium implants, and it has a very good biological acceptance when compared with acrylic, tantalum and other materials, and the search for perfect replacement continues. Cranioplasty done using planned 3D printed titanium calvarial prosthesis is an excellent option and has immaculate cosmesis. Usability and reduces the problems of fragility, infection, reabsorption, sink-in flap syndrome and problems secondary to the storage of bone in the abdomen and extracorporally. Data retrieval of 70 cranioplasties performed was done, and among which 14 3D printed cranioplasties were compared. This is a patient who underwent a split rib graft. The youngest patient was 3 years old and was managed with a split calvarial autologous graft. The results of recent 14 cases were done using indigenous titanium mesh construct was compared with retrospective data. So in 3D constructed titanium graft had no post-operative complications, whereas other 58 patients, 11 had infection, 3 had osteomyelitis, 3 had superficial wound infection, and all of them faced graft removal followed by cranioplasty. The one patient who developed intracerebral bleed post-cranioplasty died. This is the graph showing 46% males and 24% females. 3D printed cranioplasty, a cosmetic neurosurgery. The infection remains the most common complication in cranioplasties. Titanium mesh repair is difficult to contour and leaves uncovered areas. Complications are low in the period studied when compared with the retrospective data. However, cost remains the major constraint. Thank you.
This is a very important area because over my entire residency period, one of the things which I actually used to dread doing was a cranioplasty, especially harvesting the rib, splitting it, and that bone is so fragile, and in the post-operative period, even if we tie the ribs, the contouring will never be adequate. We always use, in fact, most of the patients, especially with trauma, are young people. And as you can see, there was an IT engineer who had an accident in front of the hospital, and then, so he has to go back to work. With the autologous bone replacement, you have so many issues. The burr holes, you are not going to put a cap to that. So for us neurosurgeons, this is actually a huge problem. And we never talk about it in our conferences. So that is why knowingly we have this thing. So now we are trying to tie up with IIT, because IIT, what are they saying? That we will print it for you. We actually get this printed by the Surgiware company, and it takes about 2 to 3 weeks. Now if a patient develops a syndrome of the Trephind, you will realize that we cannot put a helmet for the patient, we cannot put a, the flap and then a cap on top. So every type of experiment you try, and you will realize that if you have an implant, he did not mention that point, that we have implants that is titanium. We have about 35 years experience of putting these titanium implants in body, and we have seen that the rejection rate is very, very less. So perhaps the answer is not the other acrylic 3D printed radioplasty, it is titanium, because of all the materials, I am sure Dr. Srinivasan will agree that that is the material with the least. And as Dr. Goodrich had pointed out, that perhaps it is sensible, because anyway they fails. So if it fails, then perhaps if we use a titanium and you need to revise it, perhaps that could also be done. So this is the take home messages. The technical nuances is that sometimes if there is a collection below the flap, in the other contoured plate, there are two types of titanium plasties. One is a contoured plate. You have a plate, it is actually a plate there. The other is the mesh, the actual 3D mesh. The major advantage of the mesh is that it has pores. So you don't have a collection there which will cause pressure. Otherwise, you can't drill a titanium thing and create a burr hole. It becomes a big problem if you have a post-op collection. So then these meshes are the best. So in this design, we have been involved with the Surgiware company, telling them how the screws should be played. We still have problems with the screws, and we are still using the Codman screws because the Indian screw strength is inadequate. And placing of the screws is very, very important. So the original, through the mesh, the screws which were placed, that were going in the diplo, they were not going into the cortex, and so this 3D plasty was moving. So this is why we were trying to get Dr. Mangal interested in trying to do his Ph.D. on this aspect of neurosurgery, the cosmetic neurosurgery. It is so important that that patient, so the number of head injuries we deal is more than anything else. So this is a very, very important aspect, and I thank Dr. Mangal for making this presentation. Meanwhile, now can we have Dr. Ganapati, Professor Ganapati actually requested that because he has a concurrent oration, so he has recorded his oration, and so we will start his talk now. Meanwhile, we are waiting for the faculty to come, so the schedule of the program remains in time.
Good morning, everybody. At the outset, my sincere apologies for not being able to be present physically. Unfortunately, I had agreed to give a talk at the same time, the same day elsewhere. It is fascinating that today we are talking of technology and innovation, an initiative from IIT with VHS. In the next 900 seconds or so, I will try to demonstrate to you that today there is a convergence of engineering, science, technology with healthcare. Contrary to a general perception, this is not something new. As early as 2005, the Indian Institute of Technology, Madras, deemed it fit to appoint a medical doctor, a neurosurgeon, me to be precise, as an adjunct professor on its faculty. 3 years later, the Anna University in 2008, that is 16 years ago, also appointed me to be on the faculty. But what I think is unique and incredible and is a sign of the times, it shows where the IIT and other well-known technological universities are. Last year, December 2022, at the age of 72, a medical doctor, a neurosurgeon, I was appointed as a full-time employee of the IIT Kanpur as a distinguished visiting professor, and they allowed me to work at my convenience at a location which I could choose. A few months later, the Indian Institute of Technology Alumni Center of Bangalore inducted me as a life member, even though I am not an alumnus of IIT. This very clearly shows that there is a pressing need today for medical doctors to be closely associated with institutes of technology and science. I am absolutely delighted that at least 4 of the big IITs have already commenced Department of Medical Sciences, Technology, Healthcare, Medical School, whatever the name they go by. I'm going to spend a minute or two on reflecting how Each IIT is unique in its own way. Nearer home, the Madras IIT, which most of us are familiar with, I love the slogan they use in their website, bringing engineering to life. I think this is very, very important. Many of us as neurosurgeons have realized the complexity of the central nervous system, the peripheral nervous system, and on many occasions I wish I had a more background in the field of technology and engineering. It is absolutely amazing that IIT Madras offers a BS in Medical Sciences and Engineering, an MS, a Ph.D. program, not only for science and engineering graduates, but for doctors as well. This looks more like a prospectus of the Madras Medical College rather than IIT. Cardiology and cardiovascular surgery, orthopedics, perinatology. On the right-hand side, I had to pinch myself several times before I realized that I was on the right URL. Skull-based neurosurgery, peripheral nerve surgery, Alzheimer's, Parkinson's, spine surgery. Did I make a mistake? Instead of going to the Institute of Neurology, Madras Medical College, or the VHS Neurosurgery Center, did I go to the wrong website? This was my first thought. If you look at the other IITs, similarly, you will find, now let us take Kanpur, with which I am associated with, the Gangwal School of Medical Sciences and Technology. The building has started. Hopefully in 2 years from now, the initial operations will commence. There are centers of excellence in telemedicine and robotics, AI in healthcare, non-invasive imaging and diagnostics, cancer research, orthopedics, prosthetics, even metabolic disorders. Instead of diverging engineering, technology and healthcare, we are not even going parallel, we are converging. And I'm sure very soon there would hardly be any difference in the next 10 to 15 years between where healthcare starts and where engineering, science and technology stops. Postdoc positions have already been advertised, and within 2 years there will be a 30-acre plot within the IIT Kanpur with a super specialty hospital, a separate oncology building and so on. The Indian Institute of Technology, under which it was set up by Jawaharlal Nehru in 1956, by an act of parliament, today they have been allowed to offer degrees in medical care as well. If you look at Kharagpur, which was the first IIT, to the best of my knowledge, which started a school of medical science and technology, you can see the emphasis is more on biomedical engineering, on research rather than on clinical applications. Bioinstrumentation, a BMTE bioprinting lab, implants lab, neural engineering, neurosurgical engineering. These are the new words which are being used today. Neuro-rehabilitation. Today we have technology-oriented journals dealing exclusively with neuro-rehabilitation. We all know that as clinicians, we use the CT, the MRI, the ultrasound and so on and so forth. Every one of this was developed only in medical imaging laboratories. At Bombay, the Koita Center for Digital Health has taken a totally different perspective. And this is what I'm fascinated with, that all the IITs are complementary. There may be some overlap, but there's hardly any repetition. Here the emphasis is on digital health. Not only do they offer interdisciplinary dual degrees on masters, healthcare informatics, PhD programs in digital health, etc. I was astonished when I found that IIT Kanpur had 2,500 PhD students, PhD scholars 2,500, and I'm sure the other IITs, the numbers are also in the thousands. So this is what we are doing today. We are now talking of LLM, large language models in healthcare. AI in healthcare has become a craze which everybody, members of the public know. Consumer health, healthcare data management, computational biology, and so on. It is fascinating for a clinician like me, trained in the BC era, trained in the 20th century, to see major projects going on with the IIT Bombay, with the All India Institute of Medical Science, and so on. The Indian Institute of Science always ranked in the top 100 universities of the world. And the IIC has already started. I understand the first floor has now come up, and in another 2 years, the medical school will be ready. I am a pseudo-scientist. I got a Ph.D. in neurosurgery 10 years after my MCH in neurosurgery. There are today hundreds of people like me who are pseudo-scientists with a Ph.D., physicians and surgeons. But what we lack as of today is the formally well-trained, full-time medical researcher. How I wish these programs had been available when I was a postgraduate student. The MD PhD program, the first of its kind, will start in the Indian Institute of Science, hopefully as early as 2026. MBBS candidates who have decided, made up their mind to do a medical research as their full-time career will have a 6 or a 7-year program. 1 year in the hospital, 2nd year in the laboratory, 3rd year in the hospital, 4th year in the laboratory, and so on and so forth. In 15 years from now, we are going to have a very, very highly trained, highly qualified, full-time medical researchers, also with exposure to business administration, entrepreneurship, finance, economics, etc. I am absolutely delighted that India probably is going to be the leader in the world in another 10 to 15 years. I'm just going to give you a few examples just from the institution with which I have been associated for the last 40 years and 4 months. I'm sure many of the other quaternary institutions in India have also similar gadgets. Today, the Apollo hospital system has 18 robotic surgical systems. We have, I don't even know the number of MRIs, PET CT, PET MRI, etc. Genomic testing. Can you imagine a liquid biopsy? Can you imagine glial cells of brain tumors being picked up in a peripheral blood? This sort of very advanced laboratory testing is already available in 2 to 3 centers in India. The CyberKnife, proton therapy for cancer, 640 slice CT, and so on and so forth. Predictive diagnostics using artificial intelligence is not a paper which you present in conferences. It is actually being deployed for the last 2 years in many of the larger Apollo hospitals, particularly in their Pro Health or Master Health Checkup. Today, many institutions like Apollo have partnership with Microsoft, with Google, and several other companies. And what are they working on? They are working on the development of AI-based application programming, clinical decision support systems for liver fibrosis, empirical antibiotic therapy, and so on and so forth. 3D printing. I could not in my wildest dreams have imagined that a quaternary, for-profit, dividend-declaring company would be having 3D printing laboratories as part of its own basic infrastructure. Today, some of the Apollo hospitals have its own 3D printing customized to suit a particular individual. On the bottom slide, on the right-hand side, you can see that not only Fitbit, not only Intel, Meditronics, you name it, but several of the well-known universities globally have a very active relationship with a tertiary group hospital in the country. When I was watching Netflix, I would look at body cams, I would look at policemen having body cams. Never would I have thought that in my lifetime, I would see paramedics having body cams. And these body cams are able to transmit with 5G. We already have about 7 ambulances, 5G empowered ambulances in Calcutta and Hyderabad, very well equipped, where literally within seconds, a clinician at the emergency ward will be able to do a reasonably detailed physical examination. We are now talking of pre-hospital management. We are talking of initiating thrombolysis, whether it be for a cardiac stroke, whether it be for a brain stroke, whatever it is, within minutes, within 30 to 45 minutes of the first clinical symptom being common, the specific treatment is being actually implemented. And all this was possible only because of technology. We run at least 17 major public-private partnerships. We do almost 20,000 teleconsultations every single day. I'm just going to illustrate 2 of them, of both of which I happen to be the principal investigator, recently started a few months ago. Here you can see using smart AI-powered handheld devices for screening at the remotest part of Meghalaya in the hilly regions at a height of 8,000, 10,000 feet, trained staff, many of them are college dropouts. They are able to peer into the interior of the mouth. They are able to do a colonoscopy and so on, and transmit these images in real time to medical oncologists, surgical oncologists, radiation oncologists, and so on. Where in the world will you get an oncology opinion within 20 minutes of a patient in the comfort of the patient's home? Ladies and gentlemen, this is India. This is India 2024. We still are in a pilot project. I often feel we suffer from a disease called pilotitis, but believe me, the pilot projects are being converted to POC, proof of concept validation, and I'm very optimistic that in my lifetime, we are going to see such projects not as pilots, but all over suburban India and rural India. Can you imagine a chest X-ray being taken in a patient's house in the remotest village of Gujarat using a handheld battery operated which lasts power for 1 hour? You can see the photograph on the screen. It weighs just 3.5 kilograms, can be taken on a backpack. Yes, ladies and gentlemen, this is the chest X-ray approved by the World Health Organization, and today India startup companies have just started producing this. The product we are using is Fuji Films, but today India has already started producing this. Yes, it will take a couple of years. So a chest X-ray is taken, and within minutes it is read by a teleradiologist, and if he notes any suspicious area in the images, it is immediately communicated to our worker on the field, and a sputum testing is done. Gone are the days where I used to look at Ziehl-Neelsen stain. I used to try to look at AFB under a microscope 48 hours later or 72 hours later. Today, in 40 minutes, I can extract the DNA of acid-fast bacillus, of Mycobacterium tuberculosis with a 100% specificity and a 100% sensitivity. This is how, ladies and gentlemen, TB is going to be diagnosed in the future. We are doing pilot projects in the remotest districts of Gujarat and the Indo-Pakistan border. A TB screening program with mobile medical units has just started a few weeks ago, and hopefully in the next 18 months, we will show that this should be done. It has been my good fortune to have been a member of several committees of the Department of Biotechnology, particularly BIRAC, Biotechnology Industry Research Assistance Council. I have personally listened to more than 125 to 150 proposals for funding from various engineering colleges, universities, IIT, and so on. It is fascinating to see that the Indian medical devices is growing at an astounding compound annual growth rate of almost 8% over the next few years. 632 projects were supported in just 2 years by BIRAC alone, with an investment of 485 crores. 161 patents have been filed in devices and the diagnostic sector. 95 are already in the market, and so on. Unfortunately, the public are probably not aware of this. This was a slide I prepared for a talk almost 2 years ago, and I just didn't have time to update it. And you can see a sample of 44 projects which I have personally gone through, AI BIRAC proposals. These are the proposals most of which BIRAC has funded, whether it is glucose monitoring using IOMT, Internet of Medical Things, VR-based software, and so on and so forth. This is what is happening. Yes, less than 10% of this may go to market, but even then, it's a huge number. These are just illustrations from more than 500 digital health projects funded through BIRAC, a smart pill dispenser, innovating immunization through big data. We are now talking of the metaverse, made in India, virtual reality, augmented virtual reality, extended virtual reality, and so on and so forth. In the next 5 years, there is going to be a radical change. It is no longer import substitution. It is no longer make in India. The slogan today is make in India for the rest of the world. We have made our own MRI. I belong to the pre-CT scan era. I was the last neurosurgeon in this country who was trained before the CT scan came. Today, India makes 100% indigenous MRI, and the first MRI trial has just commenced a few months ago. So this is the India of the future. Again, a sample of healthcare startup solutions which have gone to market, whether it be face masks, whether it be a hand-cranked defibrillator for sudden cardiac arrest. Can you imagine a defibrillator working mechanically without necessity, or a solar-powered defibrillator, and so on and so forth? It is amazing what India has already started doing. I could go on, but I would stop in 2-3 minutes. I just want to give a specific example. Look at this. As I said, I belong to the era where we spoke of culture and sensitivity, where we took a swab from a diabetic gangrenous foot, where we took a swab from obvious infection. We had to wait almost for 48 hours for a culture sensitivity report. Today, ladies and gentlemen, and this is just started clinical trials, in 60 seconds, can you imagine, in 60 to 90 seconds, with a 95% specificity and sensitivity, I get a report saying that this is either gram-negative or gram-positive or E. coli and so on. How does this happen? Our startup companies have manufactured a device which shines multiple light sources from ultraviolet, visible, infrared, near-infrared, and so on, captures the multispectral images. Depending on what is the organism, each organism absorbs a certain spectra of the light, reflects the remaining spectra, and using an AI algorithm, we obtain comprehensive information about wound infection, tissue oxygenation, and wound dimensions in less than 5 minutes. The entire imaging process takes 60 seconds. You can see a sample report here. There has been an excellent concordance with the gold standard of culture sensitivity. You can see different portions here. Hopefully in 2 years, we would have had enough numbers to, perhaps, who knows, this may even replace the conventional method of investigation. I want to emphasize, and I'm very thankful to the organizers once again for giving me this opportunity. I think we as clinicians are partly to blame. Over the last 5 years, I've been very concerned about the fact that applications for funding have come from brilliant engineers, scientists, and technologists, but the knowledge of clinical care, clinical medicine is shortcoming. And when I ask these youngsters why it is, they have a standard question: sir, we are unable to get any doctor who is willing to spend effort and time. I think they are not wrong altogether. Here is an example of somebody who wanted money to develop an impulse and vibration-based therapy device. The device would deliver electrical and vibratory stimuli to discrete areas via a patch. 18 pages submitted, very detailed report, etc., etc. But the PI who submitted this application had absolutely no idea of what is the difference between a primary migraine, a secondary migraine. He had no idea what a migraine mimics, what is the natural history, that migraine has long periods of natural remission, etc., etc. I strongly feel, and I've recommended this for so many years, any proposal where the primary goal is clinical application, whatever be the technology conceived of, must have a domain expert as a co-PI from the date of conceptualization. It is wrong on the part of an engineer, scientist, technologist to develop a product, however smart and intelligent he is, and then ask the clinician to test the prototype for clinical validation. We should get the clinician involved even at the level of conceptualization. Yet another example how they wanted funds for mapping the brain, but the whole thing is very vague. No details of how many patients need to be recruited, statistical basis, etc. And what is of concern to me, there was no clinician in the study at all. Ladies and gentlemen, I could go on and on. I'm very passionate about the use of technology in healthcare. But again, as I mentioned earlier, I belong to the BC era. I believe that technology is a means to achieve an end and not an end itself. As Lars Lexer, the inventor of the gamma knife remarked, 60 years ago, that was the world's most sophisticated technology. He said, I quote, "A fool with a tool is still a fool." So viewer asked the question, which team are you in? Are you a hard hat wearing a full-time engineer, or is a stethoscope your companion, a helmet or a stethoscope? The answer today is both. Gone are the days where an engineering college and a medical college were separated 20 kilometers. Today, one building separates another building. And I'm sure in my lifetime, I will find engineers working in medical colleges and physicians working in engineering college departments. We are scientists, we are engineers, we are clinicians. Most of all, we are the ambassadors of bioengineering, bringing the cutting edge of futuristic technology to the forefront of medical research and ultimately to benefit the patient for the practice of medicine. We exist only for the sake of improving the healthcare outcome, and any technology must have this as its primary goal. So, what matters most is how you see yourself. Never, ever stop learning, because life never stops teaching. If Moses were to come down to the earth again, I'm absolutely sure that every one of his 10 commandments would be prefaced with the prefix, thou shalt digitally transform. Analog healthcare, analog medicine is of historical reasons, and it is digitalization, digitalization, and digitalization which is the only answer. Thank you once again, and again my apologies for not being physically present.
Sir. Now I request Dr. Kuntal Kantidas to speak about technological adjuncts in skull-based surgery.
Good morning to everyone, and first and foremost I'd like to thank Dr. Vasudevan sir, Dr. Anil Pandey, dear Rahul, for extending me this kind invitation to be here at the Temple of Neurosurgery of India, I can say VHS. I'm really honored. Over the last 2 days where we have been operating on the patients, it has been a great learning experience, and I must say that the staff and setup of this hospital is amazing and as good as any hospital that I have been. So kudos to all of you. So my topic for presentation today is technological adjuncts in skull-based surgery. So as you all know, skull-based surgery is one of the most demanding and complex specialties of neurosurgery. As we see, the skull base is a complicated structure, and as skull-based surgeons, either operating in this area primarily for pathologies of skull-base or skull-based approaches to non-skull-based pathologies, we have to deal with three very important structures. One is the complicated bony anatomy here, the cranial nerves which are coming out through this foramen, and lastly, the very important arteries and veins which are coursing through this area. Therefore, we can imagine that the stakes are very high, and it is not unusual for having complications or suboptimal outcomes in operations of this area. In the 80s and 90s, we had a big boom in different technical innovations in the field of skull-based surgery, and we have come a long way from those days. And from the era of radiological outcome, when the target would be complete resection of the tumor, we have come to a stage where preservation of the function has become more important than radiological clearance of the pathology. And has this made us defensive skull-based surgeons? I'll probably say no, we are more informed nowadays, and this information is because of boom in different other non-surgical fields. For example, there is extensive advancement in the field of neuroimaging. We are able to diagnose these lesions at a much smaller stage, smaller size, and we are able to take those out with function preservation. Then we have now stereotactic radiosurgery, which has made us curb our surgical radicality. And we also have improvements in the field of medical oncology, because of which many of these tumors can now be treated with adjuvant therapy, which was not possible earlier. As I said, a number of things have contributed. On the part of the surgeons have always been dedicated and passionate. Without passion, we cannot achieve anything in life. Hours of practice under a mentor or in the lab, adoption of new skills like endoscopy, exoscopy, then practicing as a subspecialist, which is somehow rather new in our country but has been there for many years in Western world. And most importantly, which is the sole focus or main focus of this talk, is the technological innovations and technological adjuncts that we use as skull-based surgeons. They have greatly contributed to the improvement in patient outcomes. This is the typical look of a neurosurgical operation room. As you see, there are often more gadgets in the theater than the personnel. And neurosurgery has always been a combination of technique and technology. But have they made our life more complicated? Probably not. As Mr. Amir Khan aptly said, that technology, in this case, he was referring to machine, is something that makes life and work simple. It saves time. And as a skull-based surgeon and the patients whom we treat, these adjuncts have not only made our life as a surgeon easy, it has made the life of the patient's life probably safer. So I shall be dealing with some of the adjuncts that we routinely use. This list is not exhaustive, but I'd like to touch upon some of the important adjuncts. And as you all know, a successful skull-based surgery has three components. One is the pre-operative planning. Secondly, execution of the plan that you have made. And thirdly, to follow up the patient and treat whatever residual that was left at the time of actual surgery. In the pre-operative phase, these are some of the adjuncts that we are using or are being used in different centers. The first and foremost is the application of advanced MRI protocols in the pre-operative imaging. For example, nowadays it is possible for us to track the cranial nerves with respect to the tumor. For example, the DTI of the 7th cranial nerve is pretty commonly done, and it can give us some indication as to where the nerve will be encountered during surgery, and we can be extra careful in that location. We can apply monitoring mapping, particularly in that area, and it can lead to successful outcome of maximal resection of the tumor and preservation of 7th nerve. As we had been discussing yesterday, nowadays preservation of facial nerve is the first priority, unlike yesteryears where resection of the tumor completely was the top priority. Then we have this tumor embolizations. Skull-based tumors, as we know, like meningiomas, can be highly vascular, and in certain situations, preoperative embolization can really help. And there have been great developments in this field in the form of improvement in the materials that are used for tumor embolization. And now hybrid operation theaters can allow intraoperative stat embolization of the tumor if the surgeon encounters a highly vascular tumor. Then we have this 3D printing, which was being discussed in detail by Professor Ganapathy. This 3D model, this 3D printing technology allows us to print the 3D model of a particular pathology preoperatively. And this can not only help us in interacting with our colleagues, our students, having a great teaching potential, it can also allow us to preoperatively simulate the surgical approach to this particular tumor and guess preoperatively as to how much of this pathology can be taken out and what part should be left behind. And of course, we have this navigation, which has a particular advantage in skull-based surgery, in that skull-based surgery, we do not see a lot of brain shifts. In neuronavigation, the main problem is shift of the brain, but fortunately in skull-based pathologies, the tumors are often adherent to the dura and the bone, and the shift is not much. So in skull-based surgery, neuronavigation has a great role to play. Coming to different adjuncts during surgery, as we all know, intraoperative visualization is very important. It is said that seeing is believing, but in neurosurgery, I think seeing is preserving. So we have different modalities from the days of operating under the head-mounted light to microscope, exoscope. We have the endoscope right now, and all this, as you can see, tools provide us excellent visualization of the structure that we are dealing with, and they not only improve the vision, they also allow us to preserve the structures. And as you see, in case of exoscope, it can allow a dynamic interaction between the surgeon and the assistant, and it has a great teaching value as well. Then we have this neuronavigation. I just want to show a small example. Here, there is a 52-year-old female who presented with subarachnoid hemorrhage 8 months back. So this was a cold SH that we dealt with. She had 2 aneurysms here. As you can see, can you see my marker? Yeah. So there was an entrecommunicating artery aneurysm here, and there was another aneurysm on the enterocoroidal artery. So in this patient, since the patient presented with a cold SH, we thought a navigation-guided keyhole approach could be feasible here. So we took this patient and we planned a supraorbital keyhole approach, as you see here. Now you can see that navigation here is very useful in that we can avoid the frontal sinus while we are designing the craniotomy. This is a particular advantage, and as we discussed during the live surgeries, that opening of the frontal sinus can have some complications. So we designed the craniotomy preoperatively before even placing the incision by using navigation. And I'll show you some of the steps of surgery here. The standard supraorbital keyhole approach. In this patient, we additionally removed the roof of the orbit in order to reduce the distance to the target. As usual, any brain surgery, releasing CSF is paramount because we need to expand the corridor there. The same thing was done here. After CSF was released, we went to the area of the optic nerve and the internal carotid artery. And progressively, arachnoid was opened and the structures underneath were visualized. We can see the internal carotid artery here. And this is the IC bifurcation, and the star area is nothing but the aneurysm. Now, as we preoperatively noted that this was the enterocarotid artery aneurysm, in such a patient, it is very important to know exactly where the perforator is arising. So here we are using an endoscope. As you can see, the endoscope, the vision is right close to the target, and we can visualize these perforators at the neck of the aneurysm, which was otherwise not possible with a traditional microscope. So delineation of the anatomy is extremely good with endoscopy, and subsequently the aneurysm was clipped, and we knew that the aneurysm neck had perforators, which was shown by this endoscopy. So it allowed us to clip the aneurysm and preserve the perforators. As you all know, perforator injury can have devastating side effects in the form of hemiplegia. And subsequently, the clipping was verified with endoscope. Subsequently, we went ahead and clipped the second aneurysm as well. Now, intraoperatively, also there are ways of mapping out structures in the surgical field by augmented reality. And nowadays, we have endoscopes as well as microscopes which have these facilities, and one can navigate through these areas by interposing these images. We also have fluorescence-guided skull-base surgery. Although fluorescence guidance is mainly used for intraaxial tumors like gliomas, but even for skull-based tumors like meningiomas, people are using it. As you can see on the left side of the image, an endoscopic excision of tuberculum cellular meningioma, you can see that 5-ALA injection can light up whatever tumor is left behind and is not easily seen with traditional visualization. On the right side image, we can see a case of pituitary adenoma where endoscopic ICG is being done. And as you can see, the tumor is not taking up the ICG as much as the normal gland. So it can be particularly helpful in small adenomas like Cushing's. And this is one case which was operated by me. This patient had a clinoidal meningioma. And after resection, you can see that intraoperative angiogram can really tell us whether the vessel handling had led to any kind of spasm in the vessel, which can have a deleterious effect in the postoperative period. And we have this augmented reality techniques where color is interposed on the artery. And this has an additional advantage in that the black and white ICG does not show the adjoining brain, whereas such a augmented reality will show you the brain as well as the vessel at the same time. So we have these technologies now. Now we have also different adjuncts to remove difficult tumors. For example, this is a case of calcified craniopharyngioma in a 3-year-old child. And we have this ultrasonic aspirators which even have bone removing capacities, the bone cosa that we say. And in this patient, we use a transcavernous approach to expose the tumor as it was a multi-compartmental tumor. You can see that the tumor is highly calcified, and it is extremely dangerous to mobilize such a tumor without debulking it. So in this patient, we utilized high settings of the CUSA to reduce the size of the tumor. And finally, as you see, once the hard part of the tumor is out, rest of the surgery is rather easy. And you can visualize important structures like the hypothalamus. As we all know, the complication in craniopharyngioma surgery is primarily because of hypothalamic injury. And we can at the same time ensure that the vessels are quite patent. The intraoperative neurophysiology is an extremely useful tool in skull-base surgery. Particularly cranial nerve monitoring and monitoring of the long tracts are very, very useful. For example, in CP angle meningioma schwannoma surgery. What do they allow? They allow identification of the nerves. They alert the harmful manipulations during surgery, and they provide prognostic information. For example, you have this patient of right vestibular schwannoma. This patient was taken up for surgery through a translabyrinthine approach. This is one approach what we find useful in certain tumors when the brain is tight and the cerebellum is bulging. This shows the exposure. And as you see, with this approach, you can land directly on the tumor, unlike the retrosigmoid approach. The first step of surgery in such tumor is to map the facial nerve. Here you can see that we have been able to identify the facial nerve in the meatus. So early identification of the facial nerve is an advantage of this approach. The rest of the steps are pretty much standard. You decompress the tumor. And as the tumor is decompressed, you can mobilize the tumor capsule into the surgical field. And progressively you can dissect. And as I told, what should determine the pace of vestibular schwannoma surgery is the facial nerve. So it is very, very important that the facial nerve is under your view. So we can see the first nerve which doesn't get stimulated is actually the vestibular nerve. The seventh nerve will come after this. We have the fifth nerve on the upper part. Now you can see the seventh nerve in the meatus. So we can visualize the nerve at the brainstem and at the meatus, and we can decide how much of the intervening tumor has to be removed. We can see the brainstem side of the seventh nerve. And you can imagine the status of the nerve, and it will be absolutely impossible in certain cases to preserve the seventh nerve without this monitoring. As we did in this patient, we took a decision to leave some amount of tumor, which was very badly stuck to the seventh nerve, and this patient, as you see, had an excellent postoperative facial nerve function, and you can barely see the tumor. This hyperintensity that you can see is the fat. So you can see the proximal part of the nerve now, the distal part, and small amount of tumor which is left behind. We are following up this patient. If the patient has a growth of the tumor, we can subject the patient to gamma knife. So if we are not able to finish the job during surgery, it is not the end of the world. We have another armamentarium in our hand as a surgeon, that is stereotactic radiosurgery. And we are really happy that both these devices, the gamma knife as well as the cyber knife, were invented by none other than neurosurgeons. Right? And this is a highly effective tool, and many of the patients where the tumor could not be resected completely, they can be controlled with gamma knife very well. So to conclude, skull-base surgery has undergone a paradigm change, and amongst a host of factors, the technological adjuncts have greatly influenced the modern day outcomes. And the future is poised for more adjuncts, and we have to accept that change is the only constant, and we have to adopt the changes. But in this enthusiasm, we have to realize that new technology is not good or evil in and of itself. It's all about how people choose to use it. Thank you, VHS. It was an honor to be here. Thank you. I'll be happy to take questions if there are any.
Thank you, Professor Guntal, for a remarkable talk. Definitely, it is such a pleasure to see a younger neurosurgeon adapting so well to technology and not getting dominated by it, but utilizing it to the best of our ability. The key thing is our surgical skill. What do you think? Don't you think that these adjuncts which we use are actually also transforming us and improving our skills further? Our dexterity, our mental dexterity is improved because of the various feedbacks which we are getting from so many directions.
Absolutely, sir. I think the technology is improving us, and we are also at the same time improving the technology. We are understanding the lacunae in the technology, and we are improving them. For example, for a long period of time, vestibular schwannoma surgery would be done only with triggered EMGs. Now people have realized that triggered EMG is direct stimulation on the nerve, and many times the patient may have a facial deficit despite a triggered EMG being present. So now, in fact, I also do in my center, we have started doing facial MEP, okay, where the cortex is stimulated and the stimulation comes down through the nerve, ultimately contracts these muscles. So how is it different than the EMG? EMG will show you the exposed part of the nerve. Many times, particularly in current scenario, we operate in such a way that we don't even look at the nerve. So when the nerve is not seen, or when the nerve inside the brainstem can be manipulated and damaged, there is no way we can, note it by only triggered EMG. So facial EMG will help. So nowadays we are doing this surgery in a combination of triggered EMG and facial EMG. So like you said, these technologies are improving us because we are knowing which of the manipulations are not good for the neurological function. At the same time, as surgeons, we have started realizing that there are some drawbacks with these technologies in the current form. And with these feedbacks, they are also improving. So I think this is like, a piggyback of each other. We are improving those and they are improving us. Yes.
Yeah, very nice lecture, Dr. Kuntal. I absolutely agree with Professor Pandey. And what I believe, in last 2-3 decades, what we have seen, as far as neurosurgery is concerned, the conventional part, as a neurosurgeon was depend on absolute surgical experience in that field on table. After surgery in postoperative outcome, we will, okay, what happened to the patient? Is there any 7 deficit? Is there any residual tumor? Will the patient develop hemiparesis? We never know till the postoperative outcome. Right now, in last one decade, I think, that this gone to an excellent level. Like, for example, yesterday we have done complex spinal deformity. The vertebra was completely rotated. So now, while we are putting a screw, exactly at the time we are checking, okay, if positive or negative response, okay, all good. So it means we absolutely know that there will be no deficit, like you have shown in the 7th now. So during table, we are so confident as a neurosurgeon that, okay, we are in. So that is the difference. So absolutely helpful.
Absolutely. I think one of the advantages of using this adjuncts is you are in a position to predict what is going to happen in the postoperative period. There are so many things that can be done. So we have just probably tapped a small percentage of it, and the future is poised for more exciting things. That is what I can
say. I have a comment to make on the same MEP versus the triggered stimulation. What happens is that even if we have cut the nerve for some reason, and if you are at the distal end, and if you stimulate,
it will get stimulated.
It will get stimulated.
Yes, absolutely.
Whereas MEP is so reassuring that you don't need to really go and stimulate, and you still know that you're removing the tumor and the nerve is still intact that time. That is a great feedback which a neurosurgeon could have.
Yeah, it brings us to the concept of multimodal monitoring and mapping in a patient. Like I was talking about this during my insular glioma surgery. People often ask you, why are you doing MEP and mapping together? So as I gave an analogy, it is like a secured campus, right? Compound, where you have a watchtower and some sniper is sitting over there, and you have 5-6 foot soldiers who are combing that area. So the sniper's role is to keep an overall vigil, whereas the foot soldiers they're combing that particular area. So when he is combing that area, he doesn't know what is happening on that corner. At the same time, the sniper only has a eagle's eye view. He doesn't have the in-depth information. So by combining the two, we can maximize their potential. So that is why most surgeons, particularly skull-based surgeons, would use more than one adjunct to complement each other. Because at the end of the day, you want to maximize the adjuncts in your surgery. Thank you, sir. Thank you so much.
Thank you. Because we have to make sure that the oration is in time. So we will request the speakers to be in this. And now can I, thank you so much.
Thank you, sir.
Can I call Dr. U.S. Srinivasan to give his talk? While it is getting ready, this was a landmark workshop. So from 1994, so now it's nearly 30 years since these workshops have gone on. This is landmark because thanks to Professor Murugayan Amritlingam and Professor G. Sarunakumar from IIT to have participated on start this next phase of journey, and this journey would be together. It would be with the technologists, with the engineers, with all of this. So I'll go ahead with that. Please go ahead.
See, at the outset, I wish to thank Professor Dr. Vasudevan, Dr. Anil Pandey for giving me an opportunity to talk in this house or temple of neurosurgery. And as I told, only thing I like to say is Dr. Anil Pandey made my life difficult. The whole book, what I have written, He asked me to talk within 15 minutes. Craniocerebral topography to neuronavigation. Right? I'll try to cover it in that time. This picture, yesterday also I showed. My dream was to give a talk here, and yesterday I achieved it. Today I am more happy to talk to you. This was years before when I used to visit this center continuously for 10 years to attend this microneurosurgery workshop as a postgraduate and later as a faculty from Ph.D. hospitals. I am standing here because of my teachers and I bow to them. In this, you had a talk from Professor Ganapathy and Dr. Kuntal. In this modern gadget era, is there a role for clinical medicine in determining the surgical outcome? Yes, definitely yes. I had a bitter experience just few days before when I was asked to come to one of the VVIP's house and examine. I never go to the thing. I told them that this is the thing. She's a well-renowned neuro specialist. She said, no, my sister, 83 years, nothing like that. Next day she became unconscious and I was forced to shift and it was a chronic subdural hematoma. What in the house I can do, even if I suspect a chronic subdural hematoma without a CT scan? So I wrote in the thing, gave a summary that to rule out chronic subdural hematoma because 3 weeks before she had sustained a fracture femur. Luckily I escaped, then they shifted and we operated. So there is a role for clinical medicine, even in this stage. Do you need the knowledge of anatomy? Dr. Albert Rotten, everyone knows, dedicated his lifetime in studying the neuroanatomy. Yes, there is a definite role. As a neurosurgeon, whether we need to know better than the radiologist with regards to interpretation of CT scan and MRI brain? Definitely yes. Radiologist gives the reports, but they don't specify. If you see the report, there will be one full page, but we need to know and correlate it with that. In a recent study published, the authors concluded due to interventional nature of neurosurgery, most of the neurosurgeons only read the report. You had to specify. As during the operative discussions, Dr. Kuntal and Dr. Jayesh told the importance of interpretation of the radiological films. It is most important to know give interpretations where the tumor is and other things and then go ahead with your intervention. As you can see in this is a part of the thing. So only, even though my topic is in craniocerebral topography, this is needed. You should know where the central sulcus is, where the motor cortex is before. There is different algorithm in this. Similarly here, you should know to read both CT scan and MRIs and they are complementary to each other. Few clinical cases I thought I'll demonstrate. This is a case of a central sulcus meningioma. If you can see in this side, you have to identify from the opposite side, that is the central sulcus. Opposite side helps you to identify the thing and localize it specifically the tumor. Welcome, madam. accurate interpretation of MRI is most important. As you can see, always compare it to the opposite side, that is the central sulcus, and this is anterior to it, sitting on it. This is that they have shown the tumor that was operated in the as a first case, day before yesterday. Again, if you have got facilities, please check the patient to the CT scan, and now with 126 slice CT and more than that available, you can do a 3D localization exactly in all the things, and then mark the incision and take the patient to the theatre and operate. So importance of accurate localization. If not, what is it? That is craniomapper. This is the craniomapper. That is there. Later, postgraduates can come and see. Youngsters. This is from Sajivar. This is the thing. This is just 1,500 rupees. It has got XY axis. You can keep it like this and take a CT scan in this. Z axis you can calculate. It has got markers. You can directly come. That is the reason why I brought this thing, for the benefit of the postgraduates. This is one of the cases where we used. Even though with experience you can exactly localize, sometimes even the experienced surgeon can localize the tumor wrongly. The craniomapper neuronavigation, you would have seen Dr. Kuntal on the day telling that neuronavigation helps to perfectly localize the thing. Craniomapper is useful in this. You get a 2D dimension only. Third dimension, Z-axis you will have to. This is another case recently we operated, an intrinsic glioma in this, using a 3D craniomapper. Yes, neuronavigation. Coming to the neuronavigation, I'll just touch upon it. Few seconds later. This is my artworks, craniocerebral topography. Before that, let me touch on the main topic. It's important, always just I'll touch. You have to mark the orbitomeatal line. I always do for every patient, whether it's chronic subdural lymphoma or anything, I'll mark the thing and then proceed with surgery. As you can see, mark the coronal suture, the bregma, the central sulcus, all these things I'll mark, because that is most important to prevent post-operative neurological deficit. You have to be careful to avoid the motor cortex. Then you know where your lesion is, whether it's in front of the motor cortex or back end of the motor cortex or exactly on the motor cortex. First the tumor needs to be marked, then the burrow site, then the dural opening needs to be marked, then the burrow site needs to be marked, and then the skin flap. This is the routine thing I always do, even as on date. This is a case which you operate, even for an ordinary chronic subdural lymphoma, because sometimes it can be deceiving that you put the burrows and it will be off the chronic subdural lymphoma, nothing will come out. And unfortunately, you will be a VVIP and you get into MS. This has occurred. So, there is topographical measurements needs to be known, and there is different. That is bregma. That is from the nasion to bregma is 12 to 13 centimeters. 5 centimeters posterior to it is the superior sagittal point. That is a motor point. You have got lambda. All these things are there, which is given in this book. In case, sometimes in CT or MRI, you will not be able to see the central sulcus clearly. Then what is used in stereotactic surgery? The Taylor-Otto lines are useful in that. There are variations, as you could see. We think, no, it is not the same. Each human skull, there are variations. These are 4 variations which has been documented in Tyrion approach. Okay. Spinoparietal, frontotemporal type, and stellate type. These are 4 variations that are there. There are landmarks, specific landmarks to identify the thing. This which, once you open this scalp flap also, you should identify the frontozygomatic structure and then identify the Tyrion and proceed with that and look for these variations. Don't take things for granted. Similarly, there are anatomical variations in Tyrion when you approach, do a retromastoid craniotomy for acoustics or whatever lesion it is. In the thing. Identification of emissary foramen is important, and there is definite relationship. Transverse sinus is superior, sigmoid sinus is lateral to emissary foramen. It is easy to put the burrow, but because sometimes you put the burrow on the transverse sinus and sigmoid sinus, I've seen and catastrophic bleeding occurring. So you have to identify, but not in all cases you can identify this emissary foramen. Sometimes if you are not able to identify the emissary foramen, then this again topography comes. But palpating the zygomatic arch through the drapes is extremely difficult, right? You have to know about it. And again, there will be variations in Tyrion which you should recognize it and then identify, take your own time to put the first barrel. After that, things becomes easy. Innovation, coming to the final part of my talk, innovation and collaboration is the most important. Professor Ganapathy beautifully explained to it. Yes, I collaborate with most of them from the time of my postgraduate studies. This is Alois, which we developed as a postgraduate in 1990, when Alois cost 1 lakh rupees at that time, with Professor Managaran. This is Dr. Pioneer, who is a neurosurgeon practicing in Salem. We developed it and we used it. And that was 1 lakh. This was 1,250 rupees at that time. I am a cost-effective, cheap neurosurgeon, to be very frank about it. Right? I got no qualms in telling about it. Right? 1,250 rupees, and we used it successfully. We presented it, and we also got into MS because they said that in 1990, when I presented, I was caught with the patent problems. I did not have a patent lawyer or anything. And when we presented it, the Alois company called me and said, we are going to sue you because you have copied our thing. It is under patent. But later I realized this we used is aluminum rods. That is different. This we used is a thing. And we kept that sponge underneath it, you can see, which is totally different. But we did not know the law. So you should know the legal part of it also before you venture now. This is neuronavigation system. What is this neuronavigation system? What is it? You would have seen everyone. But what is this? This we developed with the help of IIT Madras. Cartosian's company. We developed it and presented in the World Congress as well as World Congress in Colombia, as well as in the Agra Neurological Society of India. They are my team members. Sincere thanks to Professor Krishna Kumar and Dr. Nikhil Chandra. He started the Cartosian's neuronavigation system. Dr. M. Rambal, Mr. Bhargava, who left us. Professor Gopalakrishnan from M.G.R coordinated the things. Then where is my role in it? 2 years before, during COVID, it was developed. But it took 2.5 years. And I came into the picture to conduct clinical trials, modify it, and do it, and bring it to the market. This was my role. What is the difference? Yes, yesterday you would have seen stealth system being used. Right? This is the thing that is commonly used, brain lab and other things. Our sensor is different. And as I carried this back, this is what? It is ours is portable. You would have seen a long thing. Right? This is slightly bigger than this. Ours is a portable system. You can take it from anywhere to anywhere. One theatre to another theatre, one hospital to another hospital. This is slightly bigger than this. That check-in baggage or carry-on baggage, what you take in flight, that is the thing. You can take the thing. This is the thing. It has got a similar to it, tracking camera, probe, computer station. That is the tracking camera, probe, computer workstation. It is based upon the infrared light, red light thing. And it is a single camera. Unlike your stealth station, it's a single camera here. And this is the probe, and this is the reference array. The probe is not autoclavable. We realize it is only ETO. We are developing an autoclavable one. And as they face, registration is most important. First step is registration, and it needs a dry surface. You cannot, after a bit any scrub or anything, you cannot. There are pitfalls in it. You have to be very careful. And again, before that, yesterday, Dr. Jay should have realized, has told us that during surgery, he had problems with registration in spine because they took the MRI 5 mm, 7 mm. The company insists on 2 mm, 3 mm. This all we realized. And unfortunately, in our cases, what happens is the patient comes with an MRI or CT scan. Then we get into MS. So I do a CT scan there. Minimum 2 mm section is needed. Whether it's a dual slice CT or 126 slice CT, you have to take a 2 mm section to get the things, or else you will not get the images. This is the tracking camera, probe, sensor in this, and we need a fixation. They have moved again office. There is no need for a rigid fixation, but in our system we need a rigid fixation. We are working on it. The advantage of this is probe is this thing. Technical advantages, we compared it with stealth earlier from M.G.R and things. And we have got 15% improved visibility of the instruments and 60% more than that. The first phase, we did dummy, all these things in Balaji Hospitals, Gindi, took the pictures, because in neurosurgery, every position changes. Lateral position, right, left, head and elevation, all these things. So keeping, first of all, where to keep attach the sensor, where to keep this camera, all this is necessary. And we have made the video recording. That is most important, which most of the neuro navigation systems, because I worked earlier, that they don't give, and then we will have to adjust it. Then we use, these are large cases, yes, but in the clinical trial, first, I have to be confident that I can use it, about it. So, we used in a large acoustic neurinoma, in this case. Yes, there is no need for a neuro navigation in this, but first case we used it. Because first case we used in a chronic subdural hematoma, when I asked for a probe, there were problems. They took the probe and gave it like this. It was totally unsterile. They did not know that we had to give a sterile thing. Then we got it. Then I asked for autoclave. They said, no, it cannot be autoclaved. Then we had to ETO it. All these tribulations, trials and tribulations we underwent. You can see the thing, neuro navigation. Yes, but first case we failed in this acoustic neuronoma. And it was going, trajectory was going somewhere. I was surprised about it. We stopped it. And then I realized my assistant had kept his hand on the sensor and pushed it down while operating. Trajectory went up somewhere, right? Then I realized that I had to position my sensor so that the assistant, whatsoever he moves, left, right, center, 360 degrees, he should not rest on it. These are the things. Then after that, we succeeded in that. Still, 18th case, we got into a mess in M.G.R, where the assistant pushed it and broke it. So these are the things that can occur. As Professor Ganapathy said, there should be a domain expert. There should be an interaction between the technical people and the medical people. We should also come forward. We have got our practice, we have got our thing, I accept, but we should come forward to interact. That only will help us, help India and youngsters to totally rely upon them and not depend upon other countries and shell down heavily on their financial. This is the thing, in midline thing, few cases, midline posterior fossa arachnoids. Then we went to supratentorial surgeries, infarcts, meningiomas. These are all large cases in the trial since I am being conducting. Here it helped, as I told you. Initially we thought we can position in supine position, but neuro navigation helped us to change the position in prone position and do it because of sterility part of it. This is the intraoperative picture. It is also useful when you integrate neuroendoscopic system in removing the thing, small arachnoids. Then most important in resurgery, in endoscopic pituitary. This is a case of a craniopharyngioma. I had operated 8 years before. Again, recurrence occurred. Then endoscopic pituitary surgery, resurgery when OMR is not there. This is extremely useful in identifying the midline and going again. This is the thing. Then validation. Yes, we did in Adayar Cancer Hospital. Thanks, Dr. Vijay Sumtar, for doing the validation, taking deep cases, 3, including the case that Dr. Vasudevan operated on the day. Similar case we operated to. And Professor Gopalakrishnan validated in M.G.R about our system. There only we got that assistant kept and I think. Then we rechanged. I was not there. I told I will not come to the theatre. I like to have the system because neurosurgeon cannot go everywhere. Domain expert cannot go everywhere. The company people has to go there and things. This we did it and now we have identified. But again, coming to the market, there are certain problems, the do's and don'ts, breakup of cases, pitfalls are there. In V patient, when we turn the head, the cell system has moved on, but still we need rigid fixation. We are looking into it. I like to thank Dr. Vijay Sundar, Dr. Gopalakrishnan, Dr. Sandhanam, who used the system and validated our thing. Collaboration is the need of the hour. I always collaborate, not only with the thing. Again, I collaborated with IIT, with NeoMotion, Siddharth Daga, and they developed a wheelchair, motorized wheelchair for paraplegia patients, which is detachable, and they can, but they were not able to bring to the market and other things. So I did literally a MBA person of taking a video in front of the Balaji Hospital, and it went viral that Anand Magendra saw that, and our PM called us, and we demonstrated it. Next we were able to sell only 50 in 2 years. Next we got order of 1,000. There we got stuck. Indian problems is scaling up, manufacturing. We were caught. 500 Tamilnadu government gave, 250 orders, Madhya Pradesh government gave, we got it. We are not able to scale up that motorized company name is Neo-Motion. You can Google and see. Dr. Siddharth Dagga. Right. Then I collaborate with the SSN College on Artificial Intelligence in City, which this was presented in the NSA conference. They have gone to the Ph.D. doing, we train, we teach, and they go to US universities, take up the thing. It took me 1 year, daily 4 hours a week, to teach the students how to read the CT scan, mark it. This artificial intelligence used for in head injuries. Automatically we got the report. There is no need for a radiologist. 10,000 slices we studied, then 400 prospective head injury cases we did. Took the thing, slices. Every day we used to mark intracellular memory, subdural hematoma, all these things. Then we fought. We got 85% accuracy. After that, then they were gone. Immediately they applied for US and he is working on it. I have given the raw data, trained data to those, out of 3, 2 are working there. This is what we are doing, unfortunately. This is the 2 books I have written. The most important thing is, that will be useful for the neurosurgeons, operative craniocerebral topography for neurosurgeons. I wish to acknowledge my managing director, Dr. Ellis, and national manager for giving me the permission to conduct the clinical trials and for collaboration. Thank you very much. My sincere thanks to everyone. And as Professor Ganapathy was telling about the telemedicine, I am advisor to a company known as Clinic Everywhere. The Clinic Everywhere is a remote thing where from Delhi you can sit down, patient can come. It has got 2, one kiosk like ATM, another is a handle like this. Patient can come and talk to you and you can see. Yes, you can ask what is the difference between telemedicine, WhatsApp consultation and other things. The advantage in Clinic Everywhere is you can do the clinical examination, not only history taking, you can auscultate. When they auscultate in Bombay, that patient, I can hear the same sounds here, cardiac sounds. When the respiratory sounds I can hear, not only the pulse, BP part of it, this. Next thing is, within 5 minutes, you take a pinprick, you get the blood reports in that kiosk itself. CBC, urea, creatinine, RFT. If the patient has got fever, you take the another 2 minutes, just half ml, you get the viral markers, including COVID and viral reports within 20 minutes. And you can treat the things. This Clinic Everywhere, KLINIK, everywhere, we are into the market and we are getting orders. We are trying for finance again. Scaling up is finding it difficult. Thank you very much for your patient hearing. And I wish to thank the organizers for giving me the opportunity.
Thank you, sir. We are privileged to learn from you. Now I would request Dr. Jayesh Sardara to speak about CVJ anomalies.
Good morning to all. It is my absolute honor, privilege, and I can say proud moment for me that I am standing here in the legacy of great VHS Oration. And for that, I want to absolutely, from the bottom of my heart, thanks to Professor Vasudevan, Professor Anil Pandey, and dear Rahul, to providing this opportunity. I would like to congratulate Dr. Pandey because I'm so impressed with this concept of innovation and neurosurgery. Look at all the talk, so impressive. And we are talking about advance in the neurosciences, learning. Yeah. Yeah. So I can see a lot of youngsters here, and this topic particularly I have prepared for them because apart from the CV junction pathophysiology and 3D anatomy, I would also like to discuss the innovations in the CV junction. So we are discussing about the innovations in the neurosurgery, and this is the latest example. This man has created the history. Yesterday posted in the Times of India, this Elon Musk, and that have worked on Neuralink, and it's implanted successfully the brain chips in the first human. And it came in yesterday's time, and it's called Link. It's a compacted device of 5 coin size, and that was the first patient. And now I think in down the line of some years, we can treat or change the management for the Parkinson disease or the neurodegenerative disease. And hats off to him. Would like to thank the VHS organization to provide this opportunity. Yesterday I operated 57-year lady with a degenerative lumbar scoliosis, and look at the deformity corrected. Patient is, I'm happy that the patient is good today. Pain is reduced and doing well. Would like to thank Dr. Rahul for assisting me and our anesthetics to support. So today we're going to discuss a lot of things about the CV junction. Where to put a C1-C2 screw? What are the trajectory and direction in which C1-C2 joint can move awkward and the wrong ways, not the basic things? Why CV junction anomaly is so complex? Let's see the story behind it. I would like to show the 5-minute story of the developmental in graphical presentation. You will understand very basic things. And if you want to fix the less than 5 years child, what are the surgical nuances? Let's learn the vertebral artery anomaly in the different ways around the C1-C2, and practically how you take a decision making for CV junction and surgical principle. So mainly, this is the C1-C2 model of the normal human being, and it is absolutely normal. So once you're planning the CV junction, 2 things is very important. One is the facet joint and another is the vertebral artery. So for normal facet joint is 45-degree mediolateral to each other, and it is exactly the horizontal. And if you say from the sagittal view, it is somewhat horizontal in the same plane, and it is symmetrical. The vertebral artery is starting from the C6, and here it enters in the dorsal surface of the C2, it enters into the vertebral artery groove. In the vertebral artery groove, it takes posterior and medial turn, where it leaves a 1 centimeter bone there, which we call pars or isthmus. Then it emerges from the C2, it goes lateral, enter to the C1 foramen, and then above the C1 arch it entered to the dura. That's how the normal vertebral artery course is. So important is, so important is this 1 centimeter is called pars or isthmus, where they put a C2 screw. So if you make this quadrangle at the dorsal C2 surface, you make a center point exactly at here, and you have a 1 centimeter isthmus to put a screw. If you go directly here, it's called pars screw. This is the trajectory. Now, if you would want to put a pedicle screw, you mark the medial border of this pars, you put a dissector here, you go just 2 millimeter from the center of this quadrangle. This is the exact point for the pedicle, transpedicle screw. Now the problem arises when there is a vertebral artery anomaly. The isthmus will not be the 1 centimeter. You cannot put the 3.5 mm screw at the pars. Then the things has changed. We'll tell you what to do for that part. For the C1 lateral mass, you draw a quadrangle here. This you get below the C1 lamina, you get a 5 millimeter area. This is called lateral mass in the dorsal surface. Exactly the center of the lateral mass is the goal point. And you go medially towards the C1 body. This is the main lateral mass screw trajectory. Now another point which is very important is lease point here. So the lease point is the junction between the lamina and the C1 lateral mass. So what you can do, you just drill the little bit of the lamina and you can put directly the screw here, and This is very important point. Sometimes you deal with the vertebral artery anomalies and all. So you can start with the here. If your screw fail, then you can go up. Still you fail, or if you feel so that there is a lateral mass hypoplasia. The third point is trans point, that is translaminar point. You can directly put a screw into the lamina, and that through lamina you just dissect little bit vertebral artery. Your screw directly goes to the lateral mass. This G point, L point, and trans point. Now another point which is usually I preferred is here, through the most lateral aspect of the lateral mass, because if I do not want, I may not require a worry for the vertebral artery anomaly. I directly dissect the lateral part of the lamina, just put a dissector here. I dissect the 4 millimeter C1 lateral mass, directly put a screw, and directly enter into the body. So these are the screws just I wanted to highlight. Now, so we know that the CV junction has a 6 degree of freedom of movement, as we know. So the problem is the 6 degree of freedom of movement is, if it is dislocated, if it is anomalous, it also dislocated into not a one direction. It dislocated into 4 different directions, and that is translational dislocation, central dislocation which is going up, coronal tilt, and rotational dislocation. Now all this model I have made myself with all the moments. So we have done one study in which we have evaluated a 154 patient of the AAD and BI patient, and we find out actually what is the variation in the C1 C2 dislocation. And we find out there are 6 types of C1 C2 dislocation in various 3 Cartesian movement and 3 axes, and the most common type was 6. It was a combination of all 4, and it was contrary with as opposite to our assumption. It was combination of all 4, so much complex. And then we published, we proposed this new classification and find out that things. Now, why it is so complex? Why it's happened that AAD is associated with BI, AAD is associated with torticollis, AAD is associated with the occipitalized atlas, AAD is associated with the ACM, AAD is associated with the platybasia. Why it is so? So we'll take you to the just small story of the development that CV junction is developed from the 4th to 7th week of gestational life, from the 4 occipital and 3 cervical sclerotom. Now what happened? So in embryology, if you understand, there are 3 types. One is the phase 1 is the differentiation and grow in the first gestational type. The second is when it resegment. The second is separation. So it's separate, all the sclerotom is separate to each other. That is the last phase of the gestational life. And third phase is resegmented. In exactly precise order, they fused itself. It's called resegmentation phase. And the problem with the CV junction is after birth, it developed till the 17 years of age. So in the 3-phase CV junction is developed. Now there is a Pang theory, and he said that the CV junction is developed from the central pillar and the lateral ring around it. So central pillar we call basio-occiput, and lateral ring is called exo-occiput. So all this CV junction is arise from these 2 things. So central pillars leads to this center of the foramen magnum, C1 odontoid, and lateral ring will produce C1 lateral ring, C2 lateral mass and the lamina, and like that. So what happened at the 4th week of fetal life, there is something called genetic mutation happen, and this basio-occiput and exo-occiput become dysgenetic. And that is the basic reason behind all those complex things together, because majority of cases it occurs simultaneously. So what happened? At the late gestational life, the C1 is failed to separate from the C2. So that C1 is failed to separate from the occiput. That is the first step. So it's called basio-occipital dysgenesis and occipitalized atlas. Now problem is that goes flat skull, right? This flat skull, so in the child birth with this flat skull called occipitalized atlas and platybasia, now there is something called abnormal weight bearing, because head is large, child is small comparatively, and when he grows, because of flat skull, this odontoid goes up. Because normally, when child start to walk, this gradually odontoid going up, and this was the reason according to the Pang that this horizontal facet joint gradually become vertical. So this horizontal facet joint become gradually vertical until the 14 years of age, it's become gradually slipping upward. That's why it is said that basilar invagination is the progressive. It's not a one-time problem, it's a progressive. So once odontoid goes up, the posterior fossa volume reduced, and to compensate this, as Dr. Goel said, tonsil herniate, and that is responsible for ACM. One of the reasons that BI is associated with the ACM. Now C1 lateral mass become weak and hypoplastic, so that translational ligament, we call it transverse ligament, become weak and gradually develops into AAD. Now the problem is this exocciput also become dysgenesis, and that is parallel to basiocciput. So this condyle failed to separate from C1 lateral mass, and this is responsible for coronal asymmetry. Now, as biomechanics says, if some patient have this coronal tilt, the neck will automatically rotate to 12 degrees. And one of the reason, this AAD patient will have a cock robin position. Always you found like this. That's torticollis and asymmetrical facet joint. So this is the story why this AAD is with the BI, with occipitalized atlas, with ACM, this rotation, this torticollis, then AAD. So to prove on this, we have published this paper in the Neurosurgery, and we also found that yes, type 6 is the most common. What happens to the vertebral artery? Now, vertebral artery always follows the bone development. So if suppose normally the vertebral artery grows above the C1 arch, but what happens if the C1 is already hospitalized? So it takes, nature takes it the lateral curve, it goes this congenital occipital foramen and enter into the dura. This is very safe as far as C1, C2 surgery is concerned. But sometime in 19% of cases, that is our study, it remains below the C1 arch and it covers the posterior surface across your surgery trajectory. It's called persistent first intersegmental artery, which is dangerous. So that is the reason, if you ask me, when the cases of CV junction anomaly, when will you do the CT angiography? I will say, if there is a occipitalized atlas, you definitely supposed to do the CT angiography in all the cases. Otherwise, it may not require, because the persistent first intersegmental artery may be present in the case. So what is high riding vertebral artery? We have learned high riding. So basically what happened, if your C2 lateral mass is hypoplastic, the vertebral artery may take anomalous more medial and posterior turn, so-called high ride into the internal vertebral artery groove, and that is called high riding vertebral artery. Now this is high riding vertebral artery. Now the problem is, as I mentioned, normal isthmus size where you put a screw is approximately 1 centimeter. In high riding vertebral artery, it's become 4 millimeter, 3 millimeter. And if you are planning to put a screw like this, it will definitely land up in the vertebral artery. So the chances of vertebral artery injury would be very high in high riding vertebral artery. That is the reason in the parasagittal cut, you should be very, very safe. Now, in the development, this is the normal human development from 3 years to 15 years, and the C1, C2 models I shown you. So you see, up to the 3 years of age and maybe up to the 4 years of age, there is a cleft. The C1 arch will not be complete. There will be an anterior cleft, there will be a posterior cleft. The C2 and C1 lateral mass would be less than 5 millimeter. So if you are planning to put a screw in less than 4 years of age, it cannot be a 2 or 3.5 millimeter. It would be 2.5 millimeter. Second important point, CV junction is very weak. You need to give a occipito-cervical fusion. Don't think for only C1, C2 fusion less than 4 years of age. And please put a connector, because you are dealing with the anterior and posterior cleft. So there is a lateral instability. So these two very, very important things, remember. So this is the CT. You should supposed to see the parasagittal cut. Normal patient, horizontal C1, C2 joint, you will see. It may be oblique, it may be vertical, it may be supernumerary. This is the progressive and the types of BI. In the coronal cut, normal patient, the C1C2 facet joint is flat and symmetrical. There may be in BI vertical and symmetrical, which is usually seen. The problem lies when it is vertical and asymmetrical. That is the case where we are not going to reduce whatever you do. So let's, the last part of my talk. The 4 types is the practical. There are 4 practical types which will you find in your day-to-day OPD practice. One is the reducible AAD, in which, like this is the child case, you see that both the side of facet joint and parasagittal cut is horizontal and symmetrical. You don't do anything, you just open the capsule, it will, and in the position it will definitely reduce, and you do a C1C2 fixation like this. 6-year child with the ossodontum, I operated with only posterior C1C2 fixation. Other scenario is AAD with BI. There is a oblique but vertically symmetrical joints. You have to open the joint, you have to put a spacer in that, you have to distract it, then it's going to be reduced. And of course the AAD is also reduced. Third type, this is the example of the type 2. You can reduce it completely. You put a spacer on both the sides, C1 lateral mass, C2 pars, C2 pedicle. It's a very common type. SCM with type 2 BI. So you see there is a certain instability between the C1, C2 facet joint. So it's not a case of you only do a decompression, it happens. You need to put a spacer here and you need to fix it because there is a certain instability. I do agree with the Professor Goel. There is you need a distraction and fixation, not only decompression. Then, like this is the case, in case of BI with ACM, I usually do decompression and fixation with distraction, and definitely patient improves. This is the last case in which you see, this is the case with there is a AAD, but look at the joint. One is completely oblique, one is completely vertical. What happens if you put a spacer here? You assume that there will be a reduction of AAD, BI, but patient become deteriorated because your odontoid goes back and it will cause more neurological deterioration. For such a kind of case, you need to drill the facet joint and then you put a spacer, or you do a in situ grafting, which will help. Like this child need to operate second time and need to go for the transoral because the joint was asymmetrical. So this is very important. Let me talk about two innovation which we develop in the CV junction. First is the diagnosis of the BI. Always we know all the lines, the McCree's line, we know the Chamberlain line, we know the Weckenham's clavicle canal line. Now the problem is all this line depend on Bayesian and opistheon. Now as I told you in the embryology, this is the most variable part. Bayesian and opistheon is variable in all the cases. So in every patient it is variable. So you are not dependent on that. You should not depend on that. You need a two separate landmark which is not dependent on BI development. So we come up with the 2 points, posterior part of hard palate and internal occipital protuberance. In this study of 268 patients, we draw a distance from the tip of odontoid to this perpendicular line. We called it PIOP line. If your distance is less than 9 millimeter, we called it BI irrespective of the type. So type 1, type 2, high BI, this 9 millimeter is important. It's recently published in Neurospine journal. And we have patented this device for C1C2 alignment, C1C2 distractor and reducer. So the idea is you put a C1 lateral. The problem while you doing a C1C2 surgery is you have nothing to distract the C1C2 joint. And if you want to put a spacer, it is very difficult. You may damage the cortex. This distractor and reducer give you a qualitative and quantitative distraction. You can put a spacer easily. You can not only distract and reduce the BI, we can correct like we are distracting the joint. So I would like to thank Professor Sanjay Bihari and IIT Kanpur team to help to make this device, and this is in the developing stage. So not only it reduced, it also helped to correct the coronal tilt. On one side, if you are using like this, and also correct the rotational dislocation. So in some months it will be in the market. So thank you. And so my take-home message is occipital bone dysplasia is the basic reason behind the all complex mass in the CV junction anomaly. Less than 5 years child, it's very critical. You need a occipitocervical fixation and transverse connectors. 2.7 millimeters screw, please remember. Combined correction of the sequential displacement 3x is mandatory. And transoral odontoid decompression or transnasal endoscopic decompression, according to me, it's not an absolute procedures, may require in some cases like this. And PIOP line is a universal novel diagnostic line for BI. Once again, I would like to thank the VHS organization for this wonderful opportunity, and would like to invite you all for the NESICON 2024, the biggest conference, the Neuroendoscopy Society of India, March 28 to 31st. Welcome you all in the Mumbai. Thank you so much.
Thank you, Jayesh, because we have to start the oration immaculately in time. So we'll request Dr. Murli to make his presentation, and then we will request the other three speakers. We'll have them after the oration because there was a little delay because of the traffic today. So we will do that.
Good morning, everybody. And so I have a very different topic today. It's nothing to do with primary neurosurgery, but I've been asked to speak on innovations or a neurosurgeon as an innovator. I want to start with the statement that our mission in life should not just to be alive, to survive, but we need to live our life, to thrive in it. And we should do that with passion, because passion is something which should define you. To which, if you add some compassion, you generate respect to yourself. Without compassion, you cannot be a good human. And please also add some humor to it, laugh out loud, so that you live longer, and finally do it all in style, so that you become a true inspiration. I am Dr. Murli. I joined this organization as a resident in 2002. Dr. Ravi sir, Pandey sir, Vasudevan sir, they are my teachers. And I'm really happy that I joined here, and I owe all my achievements so far to my teachers. To talk about our schooling, our understanding towards our life. Okay, what is it that we learnt in school? We were taught to compete. What was judged on us? Only our memory power. Whoever can memorize better will score more marks. Analytical thinking, logical thinking, or interdisciplinary approach was never given an importance. Nowadays, there are few schools which try to do it, and we brand them as non-contemporary schools. Acha nahi hai, nalail in the school. They don't teach, right? But that is something where we have trained our kids. Ultimately, what have we landed up with? We have designed our kids to compete like machines. And if you have to compete, you need to have an ego. So we build up a lot of ego, and everybody are focused on what they benefit from, and everybody wants to be on the top, and they want to stand apart. That's our schooling. Then next, what did we do? We joined MBBS. What did we lack when we finished MBBS? Did we all understand that as soon as we finish an MBBS, we can open a shop, which we call it as clinic. But in the eyes of the government or the law enforcement agency or the public, you are a shop. You are under the Consumer Forum Act. You should know business. If you have to have a secretary and pay the rentals, you should understand finance. None of which has been taught in MBBS. We are all highly skilled in our subject, but right after our 5.5 years, we can become a commercial entity, and running an unit, we have no idea about. So the art of communication, how many of you have really seen in the public, like have seen how good a surgeon is? We all decide how good a surgeon is by the way he communicates. Where is communication as a teaching in MBBS? Many of the doctors get beaten up because they fail to communicate properly. Communication is effective communication. Has a person across has understood what you are intending to communicate. So that is something which is lacking. Idea of commerce, nil. Knowledge of finance, we are very dismal. Even after completing your MCH, you wouldn't know how to negotiate your salary. Whereas an engineering student at the third year who wants to do an internship is very clear about what he needs in life. Business knowledge. How are you going to be an entity? We are all professionals. If you have to pay, if you have to break even, the capital investment, what is the operational budget? How are you going to break even? How are you going to retrieve your capex into it? When are you going to see profit? See, these are very basic things which was not in the curriculum, but it is changing now. That was the story of MBBS. What happens when we specialize, super specialize? An MBBS student will not talk to an engineer. unless he's an IITian. Now, moment we do MS, MD, we won't talk to the MBBS doctor. We wouldn't have food with them. See, duty doctors will separate, consultants will sit separate. And then next what, when you become a super specialist, are you guys seeing a horn and a halo around us? Neurosurgeons. Okay, that is what we grow into. We are pumped up with a lot of ego. But what we fail to understand is that the MBBS doctor and the general specialist would be your anadatas. They can refer patients to you if you just open up and talk to them. Networking is the key. We doctors have a lot of problem in OT. Who is the problem solution? Who provides the problem solution there? An engineer. If you can go to an engineer and say, look, this is the problem I'm having, and these guys can come up with a solution. This happens in Stanford, this happens in MIT. Doesn't happen in India, but now it is happening. Things have changed. So the point here is that every single doctor is an innovator. I'm sure every single step in surgery is not taught in textbooks. While we operate, we innovate. We fail to document. That is the problem with our Indian curriculum. Second thing is, we all are an entrepreneur. When you start your clinic, when you talk to your first patient, when you're coming, you're in business. Please accept, business is not a bad term. You are a successful businessman only if you make money. Just imagine the greatest of the greatest neurosurgeon comes to the hospital on a Luna. Will a patient see him? Especially in Chennai, because I trained here, I know the psychology of people. You are a doctor, Luna la vararu. You are Mercedes la varano. I mean, that is the kind of statement people have. If not for you, you need to carry a persona. You have to live in style, like how Professor B.R.M. was. The man was really immaculate. So in my personal experience, that the essential traits which all doctors should learn, hone and practice is knowledge. Knowledge is power. So knowledge means we restrict ourselves to our subject matter. Yes, become an expert, but also have a knowledge on business. Second thing is be passionate. You are gifted as it is, being a doctor, neurosurgeon and so on, super specialist. But have passion to dream big. Have a lot of patience because it's a very challenging and tough field which we have. And we will fail, and that is the time when we need to have our perseverance. Most important is time management. 24 hours is a lot of time for all of us. But somebody who complains that they don't have time doesn't know time management. If you don't manage your time, how are you going to multitask? Okay? And building a network, your network is your net worth. The more people you know, the better position you are in. So stop being, like doctors will form friends only with doctors. In a party, doctors will form a group with the doctors. Please break that barrier, go out, talk about yourself, learn about others. There you can make connections. That can change your life. Communication skills is both active listening and effective communication, clarity of communication. All these skills are essential sets which every one doctor should learn, practice and hone, and this is a lifelong experience and journey. My journey into innovation in neurosurgery happened here. When I joined in 2002, Professor B.R.M. told me, do cadaveric dissection of vertebral artery in this place. We don't have an anatomy dissection lab. All my seniors told, that's it. You're not going to do your thesis. Take one colloid system, meningioma, and finish it. And then it was my teachers here, Dr. Vasudevan mainly, who told, Illa, B.R.M. sir has told, you better do it. Then at that point of time, I'm just coming out of MBBS. I accepted it, and then they asked me to go and do this dissection in IBMS, which is in Taramani, about 10 kilometers from here. Once I took up, they never gave me time for dissection in the daytime, so I had to go after 8 o'clock in the evening. And I did 23 cadaver dissections. At that point of time, I didn't have a clue about it. But later on, it became an award paper in NSI in 2006, and further I published in Neurology India on vertebral artery. The story doesn't stop there. What happened is this. I become an authority in CV junction. What is the biggest problem in CV junction is vertebral artery. If you can dissect the vertebral artery out, it's an open corridor. So cases, I got further awards in skull-based presentation. Or this is a term, ovexoplasty, which is coined by me, a new concept for treating CHARY malformation, which is currently under publication. I have done 22 such surgeries. The logic being, instead of plugging the obex, we try to communicate the obex with the central canal. By doing so, we have beautiful results, and I have 22 such cases over a period of 10 years with a follow-up, which I'm publishing right now. I never knew that this is where this dissection of Professor B.R.M.'s word is going to take me in life. So the lesson learned is, you look at a caterpillar and you form an opinion. Don't judge. It can blossom into a butterfly. Never miss an opportunity. Okay? The great man has some idea before he told, Murli, do this. So that was an opportunity which I'm very happy and glad that I took it. The second thing is, as a junior, we were asked to look after a chief, Professor B.R.M., the first year of my practice. And every third day I used to be at his place. And he used to sleep little less, a very, very, very light sleeper. Then we used to sit and engage. During the daytime, it's very difficult to talk to chief because they're surrounded with all big people. But at night, 2 o'clock, when sir is not sleeping, you are the only guy and then you chat. I asked him one thing. You are such a great man, achieved everything in life. Is there something which you have not? Then he told, I wanted to make a stereotactic frame. And then I told sir, then maybe I will try it. Then he had a smile, subtle smile. It looked like, what is this boy talking about? But that smile was a deep impression here, you know. I wanted to do it. And 10 years of hard work after I completed in 2007, and this patent, I filed it. That's a patent there. I hold the patent on a 100-year-old technology. Patent means novelty as well as non-obviousness. And the advantage is that we can do bilateral DBS in the same time, which is not there in any other frames in the world. So this is the frame which is developed by my team, Red Arc, which is radius of the arc, which is the first startup which is started. And we did well. We got all the certification, CE certification, ISO certification and all. But when you had to launch, COVID disrupted us. And we couldn't get up from that. There's 2 years, 3 years of break. So I am still in the phase where I have to relaunch this product, maybe in a couple of years from now. But then as a learning thing, where did I do this mistake? I became a very successful innovator. I have a patent. I delivered a TEDx talk in 2018 on this. All over the country, people know that I have a frame, internationally as well. But I don't have a frame to sell. Where did I fail? I failed in business. I didn't fail in science. I became a successful innovator. What more than a patent? But then I failed in business because that knowledge was not there. This 10 long years, like how Srinivasan sir told, that became my MBA. Even in Harvard, I wouldn't have learned that. So the idea of commerce, knowledge of finance, what brought me down was priorities in business. The priorities in business is something I didn't know. But then what happened next? I think the most important is, in every experience, we either earn or we learn. Okay, that was a learning experience. And not being successful isn't failure. Perseverance is the most important thing. And now that I could learn some of these things, the next thing I did was, when I was a medical device manufacturer, I had a pain points. Now, how can I solve that? So I went on to the other side of the table and I started a contract research organization in 2021. We called it as Dr. Clinish Research. We started it as a startup in 2021 in Bangalore, and we had about 2 companies in the first year. Right now, we have around 400 medical devices company for whom we are giving our service to. We have a company in Netherlands, and I'm traveling to US next week to start an incorporation in US as well. So I can proudly say that I am a founder of a multinational contract research organization. Currently, we are working on a health tech connect platform with authentic contents, consultants, and community, something like a social media platform. It's still in the wireframe stage. So this is in brief. What I wanted to communicate was, what is innovation and what is entrepreneurship? Innovation is more of science. You're innovating, you're improvising an invention. It's your skill set. But entrepreneurship is commerce and finance and business. Unless you learn that, you would be a failure. That is what I wanted to communicate. But I am not just a business doctor. Before I conclude, because I have my teachers here, they shouldn't think that Murli is just doing some business in Bangalore. My first love, I'm a neurosurgeon. I want to just 5 slides, I'll finish what I do in neurosurgery. From the Calvarium, I do a lot of pediatric neurosurgeries. If you can see this child with canaris synostosis, and this is the orbital floor advancement which we did, or meningiomas. I had one such case in our workshop as well. I believe in cosmesis. I do cosmetic neurosurgery. This was the FTOZ approach for this girl who had a paraclinidal aneurysm which we clipped. But the outcome is what? That passion is about outcome. That girl got married after 1 year. If I tonsured her hair, nobody would have married her. And acoustics, facial preservation, very beautifully shown by Dr. Das. And this is a very interesting case. If you look at it, third ventricular transsphenoidal encephalocele, and a child, 15-year-old girl with a primary amenorrhea. And it's around 18 such cases in the globe reported, and it was a massive skull-based procedure, split calvarial graft, and I bridged this part, and the child is doing very good now. Another CV junction, I'm just going from skull down CV junction. So this kind of a tumor which is there ventral to the medulla, you can't do a posterior approach. You have to better to do a lateral approach, transpose the vertebral artery and get in there and remove it. You can see the 2 vertebral arteries forming the basilar, and this is the clivus. That is the advantage of axis when you know the anatomy. And complex CVJ, Dr. Jayaj gave a beautiful presentation on CVJ. This girl came from Kenya with this kind of hardware, revised it, reduced the basilar invagination, and we can see how beautifully you can have a very good anatomical correction. Spine surgery, we are like Lalita Jewelries or GRT, we can tell the patients what is the designer you want, and it's 24 hours and we discharge them. But one request to all the teachers here and the students, please don't stop at this. Just don't stop at arthroplasty, fusion and TLIF. They're very basic surgeries. You can't call yourself a spine surgeon unless you also deal with deformities. Why are we neurosurgeons shying away from deformity? As it is, we have a big fight. Who's the one who's going to be treating? And if you say, I'll only do this and I won't do this, I think it's incomplete. And I got this idea because of Dr. A. Segade. I have had several mentors in life. A. Segade is a senior neurosurgeon from Karnataka, and he had told me, Murli, like, become Skoli Murli. I was ragged at that point of time, but I did learn this from 2011, and I have done a couple of surgeries. This is a girl who's a teacher from Maldives who had come to me for a deformity correction. Not just that, complex curves, simple curves. Usual thing is too much of metal, too much of bone. Oh, that isn't me. Okay, we feel like that, but I think the younger generation should break that barrier. Why? Because look at these. These are my Skoli babies. Okay, this tall girl here and this girl here, and she's a dancer as well. And we can have amazing results. Otherwise, the psychological impact on her life, we can change their life, and we can do a better job than anybody else as a neurosurgeon in deformity because we understand them. Deformity here, if you see another one, kyphoscoliosis, this is such a big hump. The goon can be beautifully corrected. Here we can see the spine is cut into two, only with the spinal cord in between, and then we rejig it. Right-angled man, because of ankylosing spondylosis fracture, it's a 13-hour surgery to straighten his neck like this. And this is my conclusion slide. I have some passion in life. Like I love astronomy, and these are real photographs which I have shot from my telescope. That's a Jupiter there. I love traveling. I'm a biker. This is my passion. This is my company. I've delivered a couple of TEDx. Professor B.R. I owe to because two big changes in my life was with influence of this man and all my teachers who promoted it and then guided me over it. I owe everything to my teachers here. More than this hemisphere, it is this hemisphere which I have a love for. More than this hemisphere, it is the smile in the patient, the happiness. It's not just I did a craniotomy, I removed a tumor, but they should feel that, they have come back to society. That is what is most important. Then you become a true doctor. Thank you. Thank you, sir, for having me here.
Thank you, Dr. Murli. Can I request Dr. Rahul Srinivasan, Professor Murugayan and Professor G. Saruna Kumar to have their talks after the oration. That was because of the thing like that, because you were supposed to speak then. And now I would go on to the main part of the function, which is the oration. And can I request on behalf of the head of department, Dr. Vasudevan, to invite Professor Suresh to deliver his presidential address. Professor Suresh.
Good morning, distinguished faculty, all the members of the Neurosurgery department, ALNC department, and colleagues from VHS. It's an absolute pleasure and honor to stand before you today to reminiscence a bit about the Department of Neurosurgery and the kind of work that is being done, and the kind of work done not only to the community but as country as a whole. I remember my younger days in VHS. It was in the 70s, 76 to be precise. At that time there was a thought process that VHS was a community-based hospital. And when Professor B.R.M. actually wanted to establish a neurosurgery department, there was some strong objections from certain quarters. They said, why do we need a super specialty here, being a community-based hospital? It was very relevant, and at that time there was a strong feeling in the Central Committee that this is what we should do. But on the other side, how could we refuse a stalwart like Professor B. Ramurthy being part of this organization. So on one side you had the philosophy of the institution, the other side you had a stalwart par excellence who was already recognized internationally and who was willing to start from scratch and do something here which we felt. So finally, as with his charisma and his what we knew he will deliver actually prevailed, and the department was started. And I think that was really the point. You can say VHS before Professor B. Ramurthy was here and after Dr. B. Ramurthy was here. It was a sea change about what happened here. Now, yes, he went about establishing the department, and I was a duty medical officer here. We had two young people, one Dr. Vincent and Dr. Vasudevan. And I was doing night duties. They also used to do night duties. We used to have a discussion and chat. And I always wondered, being a physician, finishing his M.D., suddenly he has come into neurosurgery. And I couldn't fathom, because I was also trying to make my career at that point and say, is there an option that you can go and switch drastically from one to the other, from being a physician to a surgeon? And of course, he had his convictions, and the mentor was such that he could transform anybody into a neurosurgeon. You spend sufficient time with him and he will do. And as we walk along the corridors, I remember he'll suddenly ask a question, and it will be, of course, a medical question. And if we did not answer, we know the consequences. So such was a person who instilled values, value systems, and combining extraordinary patient care, also ensured that affordable care was available to the community through the department. So over the last, now we are having the 26th Oration today. And as you go back, what has happened in the last several years is every batch, once we started the postgraduate program, the number of neurosurgeons contributed to India through this department has been tremendous. And I go back even before VHS days, because my uncle was a neurosurgeon and he was a protege of Professor B. Ramurthy at the Madras Medical College in the Institute of Neurology. And I remember a famous saying which was said when Professor B. Ramurthy comes for ward rounds. He used to say, he would ask the sister, how many patients in the ward today? And they said, 20 patients, sir. How many of them are conscious to discharge them? This was the kind of thing they had. And when patients with trauma came, they had to do a 4-vessel angiogram. And the 4-vessel angiogram had to be done by the neurosurgeon, because the radiologist was not available at that time. And from that time, the way neurosurgery, from being a passive watcher, seeing patients die in front of us with just saying, take an X-ray, see whether it's a midline shift. Today, with technological improvements and also skill improvements, we've actually come to a point, okay, we can save any patient with a neurosurgical problem. That is the kind of transformation which has happened. And I'm, in a way, I've seen the transformation as I pursued my own career, had parallelly seen the transformation. So where has it all led us? One, people are not afraid of brain tumors anymore. Then there is a system which can take care, there's expertise available, and there is technology available. And then I go to recently new innovations, if you consider how you can, before actually operating on a patient, you can actually recreate the tumor outside with 3D printing. So because I happen to know this because my sister is a specialist in that area and she's working in that area. So I went to her department and she showed me a brain. And then inside that brain was a tumor. And she said, "What is this?" He said, "Yes, this is a 3D printed brain with the tumor. So the surgeons come here before, they plan how they are going to approach, what is the depth and how much is going to happen. And this kind of, so imagine that there are no more surprises here. From absolute uncertainty to certainty of what needs to be done and how it can be done and the precision with which it can be done has all changed over the years. And this, I feel, is only because of the relentless efforts of people working in the field, the desire to do more. And as yesterday we had a small dinner, and in today morning, as I hear Dr. Murali Mohan's lecture, as an innovator, I think a number of neurosurgeons have done a lot of innovations in technique, innovations in approach, innovations in way, everything directed to how better we can ensure the patient goes home safely. Everything is directed towards only one goal, that how this patient can go home safely. So this is something quite remarkable, and we should be proud of what we can do. But as he rightly said, you can innovate as a medical person, you can innovate. And what happens after that? How can this innovation be scaled up? How can it reach the masses? How can it reach all the people who require it? And then the innovator actually sits back and feels the joy of hundreds of people using the technology which a person created. So the innovator's ultimate satisfaction, it's not in the money from the patent which comes, but it's saying my innovation is being used by centers all over the world. That is the goal that actually needs to be achieved. And as he rightly said, systems need to be in place. Support needs to come from every quarter, and of course business acumen that needs to be there is something quite remarkable. So last few days, one of our dreams of Vasudevan here was to have a neuronavigation system. And I think, if I remember right, last 10 years, he's been knocking at every door, every donor's door to make that happen. And we were very happy that a few days before the conference, the system arrived. So I got an excited message with a picture saying, system has arrived, please come and see it. We are going to use it for the workshop. But you know, complicated equipment require not only the arrival of the machine, but you have to become friendly with the machine. You have to, literally you have to get married to that equipment before it will start responding to you in the way you need to do it. So, but nevertheless, the dream has been achieved. Relentless pursuit is what makes this happen. So over a period of time, I think our department is getting better and better equipped. And but if you also imagine, nothing was stopped because these equipments were not available. So in other words, we had the traditional expertise which was there, and as technology advanced, there is a desire to get the technology. Sometimes there is a gap between the desire and the actual achievement of what you want to do, but the patient care does not stop. So in spite of all the constraints, the tremendous amount of work that's being done in this department is a thing we are always and will always be proud of. And that, I think, is it's something to say that doesn't matter. Our job is to give what is needed for the patient, and we will do it irrespective of what is there or what is not there, and we can achieve it. So this is another big lesson we take from the department as always. The way the systems are organized, the way the spread of knowledge. So the other goal which they always have is how can we translate our experience into ensuring this experience goes to other people in the field. And that's why on an annual basis, when this meeting happens, I remember, I always remember that the planning starts months ahead. That right at the nearly a year ahead, they'll say what's going to happen for tomorrow. If at the moment you finish this oration, probably in a month's time, they'll start planning for the next oration and how the workshop is going to happen. So that is the kind of single-minded goal, and the number of monograms which have been published from the department and the textbooks that have come. And above all, I think we should always ensure that the ladder in which we came up is never forgotten. That we climb up, we can only climb up on the shoulders of giants. And those giants, over a period of time, sometimes these giants get forgotten. But if you go up the second floor, if you go and see the museum, in a few minutes, you can relive Dr. B. Ramurthy there. That is the most beautiful way they have established the thing, and I often try to go there, spend a few minutes, and as you keep seeing that, you feel very inspired. You feel, here's a person who has achieved so much and who has helped us also achieve so much. So why should we not try to aspire for something more like that? So from these stalwarts, we not only imbibe their qualities of leadership, qualities of excellence, but also we become responsible for inspiring the next generation as we go along. So that's a legacy which we need to follow up and follow through. So the last one I would like to say is, as we go along this journey, we know that there are several hurdles that will come on our way, but at the same time, the world is running at a very, very fast pace. So even if we have to remain where we are, we need to keep running. We need to keep running to remain where we are. But we need to run fast to actually progress and show the world that we are actually leaders in the medical. I'm also very happy in my own field, for example, how neurosurgery has come into it. I'm a fetal medicine specialist, and in the last 5 to 7 years, we always thought when a baby has a spina bifida and CHARY malformation, this pregnancy is terminated. That's what happens even now. You identify, and 95% of spina bifidas we identify by 12 weeks of gestation. But there are patients who come in the second trimester, and what is the hope? And there are parents who come and say, I've been waiting for this baby for 10 years, I don't have a child, but can you do something that this child will be also have a life? You say, spina bifida, you're going to have neurological problems, you're going to have this, you're going to have this. Is there something which we can do in utero before the baby is born? So this thought process fetal surgery started many, many years ago, almost 40 years ago. But now more recently, the issue of spina started with hydrocephalus being treated in utero by putting an intrauterine shunt. Then they gave it up, saying this is not good because 50% of them have a neurological deficit after birth. So counseling the parent became very difficult. So, but then more recently, the open fetal surgery for spina bifida became a reality. So it was initially there was a big challenge because maternal anesthesia, the risk for the mother was very high, and they almost lost a mother post anesthesia, post surgery. But then they wanted to say, should we actually continue this journey? But then they said they found out methods by which the mother will be safe, and after 26 weeks you can operate on the baby, just bring it out, do the spina bifida repair and go back. And those babies have been found to have the number of them require shunting after birth, and the neurological outcome also is much better after birth, because the healing process in utero is much better, and I think the tethering does not happen as it happens after birth. So, but then the problem came that you can operate on the patient, this baby is fine, but they have to do a classical section, put a vertical incision, and then the mother loses reproductive health after that. She cannot have a baby after that again, because the risk of uterine rupture becomes very, very high. So as they were trying to see what can be done, so can we convert this open surgery into minimally invasive surgery? And that was born fetoscopic repair of spina bifida. So fetoscopic repair of spina bifida is done in several places and several countries now. Of course, there's always a debate, open surgery is better or a fetoscopic surgery is better. But the current evidence is actually trending towards, yes, it is possible to do fetoscopic repair in cases. And that actually tells us that we can take neurosurgery to the in utero period. And of course, all of us have heard of this remarkable achievement of managing a vein of Galen malformation through in utero embolization, which has also happened recently in the US. Of course, we are a long way into ensuring that every patient will actually have access to that. But somewhere somebody has to make a beginning. When we start thinking of doing something, for the past 5 to 7 years, we've been thinking that we should start spina bifida repair in our country. Several discussions are made and all the things are done, but it will come together. I am hoping it will come together in the next few years, because we had an Asia Pacific meeting in 2017. At that time, the team got together and said, yes, it is feasible and it's also the right time. The idea is, in the Asia Pacific region, which are the centers we are going to do. And as we were thinking about it, already Taiwan has started doing, Hong Kong has started doing, and it's time that India also got into that bandwagon, because even though the number of cases might be very few, there are some patients who actually require this to be given to them. For them, this may be the only option of having a child. And when we see parents who are in absolute distress and tell them that here, yes, we can do something for you, give them some hope, they are willing to take some neurological deficit, doesn't matter, as long as I see my child alive and doing things what other people will do. We are quite happy. We don't want them to be athletes, we don't want them to be anything, but we just want to hold a child and hug. This is what some mothers have told me. Do that for us at least. So I think we have to move further, and we have to ensure that neurosurgery is taken to the fetal period and antenatal period with such excellent quality and the quality of care and the skill of the kind of neurosurgeons we have in India. We should actually, and with 28 million births annually happening, about 1 to 2% of them will have spina bifida. So it's time we have. And also even antenatal counseling, for example. Increasingly, mothers where we find neural tube defects, they want to talk to a specialist about long-term outcomes. The obstetrician or the fetal medicine specialist is not equipped enough to talk about long-term outcomes. For example, it's a closed spina bifida. So what do we tell? Should this pregnancy be continued? Should it be terminated? Is there an option? Which is there? What is the level of deficiency or deficit the baby will have? This can be done only by a specialist. So it's time that neurosurgeons got into the act of antenatal counseling, and that is a very felt need. Because whatever said and done, whatever tried of preventive methods we do by giving folic acid and B12 to the mother, the bottom line is neurological defects are going to be the most common antenatal defects which we will find. There is no doubt. Next only is cardiac defects. So we need an army of people. We need a pregnant mother to access a neurosurgeon for antenatal counseling, meaningful counseling, so that they can take informed decisions about what we do. So I hope the Association of Neurosurgeons will actually come together and provide antenatal counseling guidelines, for example, and have and also say in each region, say, I'm here, if you have any help, I'm here to help you. That's what we are hoping that will happen. Because this I'm telling in selfish interest, because the field of fetal medicine has expanded so much. Today we have hundreds of fetal medicine experts in India, and it's increasing by the day. And so many of these mothers can go beyond just saying, here is a neurotube defect, go and terminate pregnancy. When they terminate pregnancy, the amount of grief and the amount of guilt that happens is so high. Counseling actually, I believe, will help to remove the guilt conscience from the patient. They may ultimately decide to terminate, but then they'll say, I terminated because I know the consequences. These consequences are there, and that's why I don't want this pregnancy. So 6 months after she terminated, she thinks about it and says, I made the right decision in my life. Otherwise, supposing for a year or two she does not have another baby, she says, maybe I should have kept that child, maybe I should have braved that and gone ahead. So that guilt feeling many women have, they don't express it, but when you actually go and sit and talk to them quietly, they start expressing and they burst out in tears. All this we have experienced in day-to-day practice. So this is something which is required, antenatal counseling by the neurosurgical team for neurological problems that can come in the fetus. So thank you very much for this opportunity, and I'm very happy that program is going extremely well, and I'm sure the rest of the meeting also you will enjoy. Thank you. And I thank, of course, all the experts who always come whenever called to VHS. It's a matter of big pride and honor for us, for all of you to be here. Thank you very much.
Thank you, sir. I would request Dr. Prof. Anil Pandey to introduce the orator.
So one of the giants whom history will remember gave a series of talks to Mahatma Gandhi, and he presented these talks to Mahatma Gandhi. He was actually a very large, one of the largest practitioners of modern medicine in Chennai, and then converted to Ayurvedic medicine, again reached the pinnacle of that, had wide-ranging interests in history of medicine, history of ancient Indian medicine, and he was also an author of a multi-volume textbook of Ayurveda, of which I have only read the first volume, which is on history of the Ayurvedic system. It's amazing, his erudition, and also the character of a man. The character of a man shines through. So at both entrance of the department, in fact recently I put his portrait on the east side of the department also, because I realize that it is the legacy of these people which needs to be pushed to the future. And this is why this oration has been named after this giant. Dr. PRITHIKA CHARY is a very renowned neurologist and a neurosurgeon. So that is something which is absolutely outstanding. She's part of our department in the way she, sort of educates, helps us in our planning our residency program. And she is India's first neurophysician and neurosurgeon, editorial advisor of epilepsy, as her area of interest was epilepsy and epilepsy surgery. She was part of Apollo for many, many years. She did her senior house surgeonship in internal medicine in 1971. In 1972, Madras Medical College, where she trained for M.D. General Medicine between 1972 and 1974. She was the assistant professor of neurosurgery, neurology, medicine, neurodiabetology at Madras Medical College between 1975 to 1982. And she was a postdoctoral fellow in Madras Medical College between 1982 to 1985. She has been a consultant neurologist at Apollo Main Hospital, also a neurosurgeon at the same place. She was awarded the Adjunct professorship of the M.G.R Medical University in 2010. She is head of the Department of Neurology earlier at the Global Hospitals from March 2012 to 2013. A senior consultant neurologist and neurosurgeon at Kauvery Hospital at TTK Road. She is very fond of music, travels a lot, and is very curious to learn what the world goes around. She has a childlike sense of wonder, enjoys gardens and museum alike, and always learns from everything around her. She's been involved with corporate schools, colleges, NGOs, and management since 1996 in the various aspects of cognitive, behavioral neurology, neurorehabilitation, and mind, brain, body medicine. She believes that life is to be enjoyed and not just endured. She is a contributor and a person should be better after she has passed through. So, ladies and gentlemen, I present Dr. PRITHIKA CHARY as the 26th Dr. Achanta Lakshmipati orator. Can I request Dr. Vasudevan, the head of department, to come?
It's a great pleasure and honor to present the 26th ALNC Day Oration Medal to PRITHIKA CHARY, who is a renowned, as Anil Pandey put it, renowned everything. But the most important is she is the pet student of Professor B.R. It gives me great pleasure in presenting this medallion to her.
This is for her. Okay. Good afternoon to everybody. At the outset, I want to thank the ALNC department for selecting me as the ALNC orator for this year. I owe a lot to Professor B.R.M. and it's a matter of pride for me, and I think it's a privilege also to be able to be here this morning. Dr. Suresh earlier just mentioned that we stand on the shoulders of those who went before us. And I actually stand on the shoulders of Professor B.R.M. for many things. See, standing on the shoulders means you go up and climb on top of the shoulder. But you've got mentors who sit down and take you up on their shoulder. And that's exactly what he did to me at many stages. After I finished my MD, I had this crazy idea that I could do the Ph.D. in neurology because I had some very interesting cases which I had seen and they were all neurological. So I went to him and told him, sir, I just want to publish this. It's an interesting case, and you help me with this during my MD thesis. He said, no, it's too good. Go and register for the PhD. I didn't even think that I could register for the PhD. So I turned out to be the first PhD in neurology out of the Madras University. Thanks to his vision, as Dr. Murali said earlier, he came up with certain things and you just did it. And still later on, what happened was, I was posted in the government Tamilnadu service. I was posted to Kunur and I had to change over to an academic institution because I'd finished my MD, and they said there is only one post available in MMC, Assistant Professor Neurosurgery. I was an MD General Medicine, mind you. So I went to Professor B.R.M. and said, so there's no other post available. If I don't get this posting, I'll have to go to Kunur and do work in a primary health center. My father's had a heart attack and he needs me here. So he said, just join. And this is not meant in any derogatory fashion. He said, even a chimpanzee can learn neurosurgery. Don't worry about it. You just join. And you will bring a special value to the department because we have a lot of medical issues which we neglect. And you will be the physician who will guide us. So this acknowledging, this appreciating, this, finding something wonderful in you was a knack which Professor B.R.M. had. And many years ago, an Indian Express journalist called me and said, we are doing a piece on Dr. Professor Ramurthy. We are talking to all his students and colleagues, etc. Can you give me one word which will describe him? So I said, nurturing. That is what this man was capable of. He has nurtured so many people, medical, surgical, whatever. And he has made such a big contribution to the field of the entire neurosciences, not just neurosurgery, but entire neurosciences. And I think many of us in this country owe what we are or where we are to him. So my initial start is to express gratitude and bow down to this doyen. Of course, I also feel very blessed and bow down to the divine for giving me the strength to get through each day, because as a woman neurosurgeon and woman neurologist in a man's world, the DM neurology course in MMC, I was the first lady to join the DM neurology course there. Before that, only men were doing it. So it wasn't very easy. In my MD course, there were 20 boys in my class and I was the only female. So it has been pretty challenging, to say the least. But I have been very blessed because somewhere along the way, the right person appeared at the right time, the right mentors came in, the right opportunities presented themselves. And luckily, I had my eyes and ears open to be able to take the opportunity. As earlier Sir Murali said, you have to know when to seize the opportunity also. Coming to the topic of today, epilepsy is something that I got interested in the mid-80s. I had finished my DM neurology in 1978, and I was practicing neurology. By about the early 80s, I became very frustrated. There were many days I used to go back home and think, what have I contributed to my patients today? Because I would make diagnoses like olivopontocerebellar degeneration, motor neuron disease, and conditions like that, which had big fancy names, fancy tests, and I wasn't making a big difference to the patient. So I was sometimes feeling dejected. Should I, subspecialize into something? I get along very well with young people. And I said yes. So I'll choose epilepsy as a subspecialty because I can make a big difference in a lot of lives. And there are a lot of myths and stigma and all that. And so we can really work on improving the lives of these people. And that's how I sort of got interested in epilepsy and started working with epilepsy. And we know that 50 million people in the world suffer from epilepsy. 80% of them are in low-income, middle-income countries, and there's a 75% treatment gap. So that's a huge opportunity for us to make a contribution and change lives. We all know that it's a very challenging medical condition. It doesn't have only one facet to it. It involves healthcare, it involves the occupation, it involves their schooling, their education, their employment, their marriage, their pregnancy, their elderly. When elderly get seizures, it has a completely different ball game because drug-drug interactions happen with other comorbidities. So it's got a wide spectrum. And it also needs, the etiology also can be very varied, and it needs both the assistance of general physicians, multidisciplinary team, neurologists, neurosurgeons. We know that it also transcends demographic boundaries because you can get epilepsy at any age. Though there are segments in the earlier age group and the later age group after 60 where it's higher, we know that it can affect all ages. Also, its reach is not just to the patient. It extends to the family, the friends, the community. And the economic burden of epilepsy can be quite huge because there is a lot of cost incurred, not only in the investigation part of it, also in the treatment part of it. Because anti-epileptic drugs are pretty expensive and you have to take it for a longer period of time. But the other thing about epilepsy is it's not rare. It's very common. 1 in 150 people world over have epilepsy. And they always feel they're sitting on a bomb because it's the unpredictability of seizures. You don't know when it's going to hit you, where it's going to hit you. And we know that once it starts in childhood, it can persist into adulthood, it can interfere with the education, employment, and having a normal life. And very often, we find that sometimes they get stuck into one avenue of work. I chose this topic and because Professor B. Ramurthy taught us when we were training in the Institute of Neurology that the neurologists and neurosurgeons have to sit across the same table so that we work together and we resolve things straight away. The other day when I was speaking to Anil, he said he's trying to bring back that culture here. And so I felt that epilepsy was a good example where neurologists and neurosurgeons need to work together and can work together with so many other specialists. So, because it's such a widespread, such an impactful condition, we know that there is an unequivocal need for collaboration. And what is the role of neurologists? As neurologists, we confirm the diagnosis of epilepsy. We know that many people who are thought to be epilepsy, when they are referred to a specialized unit, are found not to have epilepsy at all, but other conditions. Then neurologists help in the investigation and identification of the type of seizure because we know that treatment depends on the type of seizure. They advise about drug treatment, diet treatment, lifestyle advice, non-pharmacological interventions, and offer psychosocial support and help increase awareness and prevention of stigma and myths and misconceptions. And they also play a role in the recognition of which are the possible patients who might benefit from epilepsy surgery. So we know the definition of epilepsy has been recently coined. I'm not going to read this out because I'm talking to an informed audience. And if you look at the demographics, we find that males have epilepsy much more than females. But what was interesting in this article, it's an Indian-based article, is that 2.73 million women with epilepsy in India, 52% of them belong to the reproductive age of 15 to 49. So I see a lot of young women and see them through marriage, pregnancy, and that is a huge contribution you can make. And because we were talking about fetal medicine and what can be done for women having children, the obstetricians consider epilepsy as a high-risk pregnancy. So we work with them, and we've had any number of successful pregnancies and happy mothers and fathers. Age, of course, it's below 10 very often is the highest incidence, above 60. And urban-rural, like in most diseases in India, the rural is much higher than the urban. And if you look at the urban, the rural differences, why they occur, very often there isn't a lot of epilepsy can be prevented with good maternal and child care. So the lack of good antenatal, postnatal care, birth injuries, malnutrition of the mother, systemic CNS infections, various neurotrauma, babies sometimes are dropped, and limited services in rural areas account for this increased incidence in the rural area. And we've got a lot of other background things which we find in the maternal factors which can contribute. So we need to understand epilepsy. We know that the recent classification has simplified it and made it into focal generalized. And we know that focal seizures start in one area of the brain, and generalized epilepsy starts in one area and spreads to the rest of the brain. The ILA classification, or the International League Against Epilepsy classification of epilepsy, has gone through several changes. But right now, in 2019, they've sort of given a very simple framework where you separate them into focal and generalized, and then you've got an etiological basis, the epilepsy syndromes, etc., covered in that. And very often in epilepsy, like I said, it gives you an opportunity to help the patient in more ways than just drug treatment. You're able to tell them that there are a lot of triggers and that provoked seizures are different from unprovoked seizures, and that they can actually have good quality of life if they follow some lifestyle guidelines. And we know that the etiology of epilepsy is different in the newborn versus the child versus an adult versus in seniors. And so there is a lot of awareness which we can create in people with epilepsy and their families. The neurologist is responsible, I told you, for diagnosis and monitoring. So we have the EEG, and we've got tremendous advances in the EEG, which includes our video EEG, long-term monitoring, etc., which gives us better localization. Neuroimaging has completely transformed the neurosciences, because when I trained and became a neurologist, we used to do carotid angiograms to make diagnosis of anything in the brain. And then towards the end of my training, we had what's called as the radionuclide scan. We would get very excited when we saw all those dots and concentrated dots in one area saying that's a tumor there. But I'm so blessed and I feel so grateful to have been alive through this transition and to see. Even today, whenever I put up an MRI, I say, thank you, God, for this wonderful modality where I don't have to poke somebody into their carotid, create a hemiplegia, inject Hyalase subcutaneous because they develop a hematoma. This is what we used to do. And of course, the SPECT and PET and all of these have given us tremendous advances in the functional and structural localization of the epileptogenic lesion. And the PET MRI has been very valuable, especially in the difficult to treat patients. Medication management, here again, huge advances have taken place. Where we had only 4 drugs: sodium valproate, carbamazepine, phenobarbital, phenytoin. That's all we had. And for many years, yes, we made many people all right, but we would have to monitor them for side effects, and if they were allergic, we were stuck without a medication, etc. Now we've got a huge range of medicines, and like I said, the pregnant woman with epilepsy, she's got safe drugs which we can use and still give her a very good outcome of pregnancy. So we've got all these drugs now, and we've got a huge armamentarium from which we can work with. And important thing which neurologists probably do for epileptic patients is building the trust and communicating to them that life can be okay. It's all right. Epilepsy is not a sentence for life. It is something that we can help you with. Still, we are only treating seizures, mind you. And maybe if we know the etiology, we are treating that. But we are really not curing epilepsy. We have not gone to the root cause yet. But still, we are making a huge difference in the lives of these patients. So we have to have this holistic approach. And the responsibility of the neurologist becomes to be compassionate, to be knowledgeable, and to establish the diagnosis, treatment, and patient support. What is the role of the neurosurgeon? They become essential partners in the comprehensive management of epilepsy, because surgery becomes a viable option when epilepsy is drug resistant, and this has been another huge advance that we have experienced. In 1986, I made a decision to go back to college and do my MCH neurosurgery for 5 years. So when I finished in 1990, epilepsy surgery was, the buzzword everywhere. Everybody was saying, this is an option, this is an option. And I'd been working with epilepsy prior to that. So on my own funding, I borrowed money, I took a bank loan, mortgaged my house, all kinds of things. And I went to London and trained with Mr. C.E. Polke for epilepsy surgery. Now that department was such a fantastic department with holistic management that Dr. C.D. Binney was the neurophysiologist. We had Robert Elvis, who was the neurologist. We had Robin somebody, who was the neuropsychologist. It was a comprehensive department. So after the 3-month stint, while I was coming back in the plane, I said, I want to go back and start a comprehensive center. And this name, EPICENTTRE, which I gave to the center, came to me then in the plane. And it was an acronym for Epilepsy Institute and Center for Treatment, Training, Research and Education. And I came back in 94. I didn't have much funds, but I was determined to start. I talked to my senior neurology mentors. I talked to my colleagues. They all said, you're stupid to go and start a single disease specialty. If it's general neurology, we'll join you, but otherwise, no. And my neurology teachers didn't really encourage me. Then I went to Professor B.R.M. and said, can I bring it into ALNC? He said at that time things were a little stormy here for various reasons. And he said, I'm sorry that I like the idea, but I can't give you the platform. But let me tell you, don't stop, don't quit. You just start it. So when I did the first puja, I took a place which I couldn't afford. It was 25,000 rupees monthly rent. And my whole savings was 5 lakhs. But Dr. Binney had given a 365 days at site. And I bought a telefactor video EEG machine for 22 lakhs with loan and this and that and all kinds of things. And that's never given to an individual, especially, what is the guarantee that I'm going to pay back? But he said, I'm sure she will do it. He strongly recommended it to Telefactor Company. So I started EPICENTTRE in 1994 in a private premises, rented premises. And we introduced the first video EEG for the entire South India private sector. And because we were transitioning from analog EEG to digital EEG at the time, Warren Bloom in Canada, I had visited him and he sent his senior technician and we did a 1-week-long training of transitioning from analog to digital EEG. That senior technician took it. I did a workshop for technicians from all over the country. We had about 15 people coming in training and learning digital EEG and transitioning from analog to digital EEG. And from there we took off and we started doing video EEGs. I visited all the video EEG centers in the country at that time. One was in Chitratirunal, one was in Hinduja, one was in AIMS, and in Hyderabad, the NIMS. And I found out how they did it, took down all their protocols, took down all that, what could I charge and things like that, and came and started the process here. And that really took off, but it was a tremendous financial and physical struggle for me, mental struggle too. And in fact, some of my non-medical friends who were helping me said, we are losing a good doctor and getting a frustrated administrator. So Murli's point of being aware of business is very relevant here. So with that, we were working very hard. Then we got a name where people were coming to say, that lady doctor in Chennai who sees epilepsy. 97, I told you opportunities come when you put your mind to a single cause. Apollo invited me to bring my EPICENTTRE into that. And that is another whole big story. So we introduced epilepsy surgery in Apollo in 1998. We had Professor Henry Sylvanus come. We learnt all the strategies. and one of my neurosurgical colleagues, Dr. Sendilnathan, had come. I had told him, I had met him in England, and I told him, 1 year you train in epilepsy surgery. When you come, you can be part of our team. So we kicked that off. And why we are talking about this holistic collaboration, cooperation kind of thing is, Professor Ramurthy, right from the early days, never separated the neurologists from the neurosurgeons. As you can see, as you can see here, you can see Professor Kanaka, Dr. Ramurthy, Dr. V. Balasubramaniam, Dr. K. Jagannathan, Dr. K. Srinivas. So neurologists and Ramanujam, they all worked together. And that was a culture that was part of the Institute of Neurology. I am privileged to have worked with doyens like Dr. K.S. Mani and K. Srinivas and all these wonderful people who have shaped us. And as early as, I don't know when, you probably know the dates, the BRM used to do in ALNC some corticographies of a sort. And I remember coming and witnessing those things and learning from it. Of course, today we have VNS, we've got RNS, we've got DBS, we've got a lot of new ways in which we are approaching epilepsy. And there is a huge big protocol we have a whole algorithm by which we can isolate these cases. And there are newer treatments like laser interstitial thermal therapy and stereotactic radiosurgery, which is emerging. So epilepsy surgery is a collaborative effort. It cannot be done separately by any one person. So we need to work together. And instead of neurosurgeon versus neurologist, let us be neurologist and neurosurgeon is what. And this initially, yes, when the neuroscience departments were developing, because we had each was developing a lot of core skills, we needed to have separate sections. But I think now it's time for us to blend together and offer cross-training, specialized training of neurology for neurosurgeons and neurosurgery for neurologists. And collaboration, cooperation, coordination, communication. This is the key. And here again, I'd like to acknowledge that I owe that thought process itself to Professor Ramurthy. It has been my privilege and my blessing to present my PhD thesis in Budapest at Emil Pasteur, Professor Ramurthy. That was my first trip abroad. And in Frankfurt airport, what happened, I didn't know that you get this boarding pass for even after the stopover. Because that was my first trip. And I was sitting and waiting to be called. And then I was getting announcements on the PA system saying, Dr. PRITHIKA CHARY, come, we're waiting. Professor Ramurthy was standing at the entrance of the plane and saying, where did you go? I said, no, sir, I was waiting to be called. So he was waiting to make sure that I'm in the flight because I didn't know. And he was such a caring, such a affectionate person. So it's really been my privilege to have been given a talk in his 80th birthday celebrations. And this was when I was doing my DM neurology, and you can see here the whole department, Dr. Dibal Rao, he was doing his neurosurgery at the time. A lot of wonderful experiences. We've had the privilege to meet Yasir Gill, Dr. K.S. Mani, Nimal Senanayake from Sri Lanka, June Wada, of the Wada test. Then Professor Kanaka. Day before yesterday, I gave the oration, the first inaugural oration of T.S. Kanaka, oration in the Chennai Neuro Association. And you'll find that what I actually owe my entire EPICENTTRE experience to is these two in this. This is Hanneke de Bo. And at one conference there, she was the president of the IEA. And she said, a full life with everyone, like everyone, in spite of epilepsy. So that became my slogan for EPICENTTRE. And this is Professor Polki, this is Dr. C.D. Binney, this is Alarcon, he was doing his research there, this is Dr. Praveen Ashan, that's me. So I have had the privilege to be guided. And Professor Ramurthy always said that a visit to Montreal Neurological Institute was what inspired him to set up the Madras Institute of Neurology. And so I made it a point when I went to Montreal to go to the Montreal Neurological Institute and look at it like visiting a temple. And it was truly an experience like a temple. So we have to have the 4 C's of partnering: collaboration, coordination, commitment, and communication. And we need to integrate neurology and neurosurgery in all our departments, so that we can, in instances like this, where there's a complex partial seizure with an unidentified focus, we can help identify, there can be intraoperative monitoring, we can discover the focus, and we can operate and help the patient. Medically refractory temporal lobe epilepsy, we all know the usefulness of amygdalotomy and temporal lobe resections. Also, when we have FCD, FCD is another wonderful thing which is amenable to surgery and gives a lot of good results. Intractable epilepsy with a concurrent brain tumor. So these are all typical instances when neurologists and neurosurgeons can cooperate with each other. And of course, when neuromodulation fails, and you've got palliative procedures which you can do. Also, post-traumatic epilepsy following head injury, very often neurologists and neurosurgeons have to work together. So when we work together, we save a lot of time for the patient, and also we make a more accurate diagnosis. So when the neurologist feels it's necessary, that is why in the Institute of Neurology in Chennai, we could sit across the table and literally ask straight away, what can we do? And I think that's an excellent model that all departments should follow. So we collaborate on treatment plans, and they align it with the patient's thing. Cross-training is the answer. So there were many people when I was doing my DM neurology who had never seen a living brain. And that's no way for you to train to become a neurologist. And cross-training, collaboration. So the advantage of collaboration is that we develop a more holistic approach to patients. CMEs, surgeries can be demonstrated even to neurologists, though that's not being done. Or you can make a neurologist. I used to tell anybody junior who's training in neurology to make it a point to go into the theatre. So if we have worked up a patient and the patient needs surgery, I tell them follow the patient to theatre, so that you actually see it to completion. And case conferences, boards. So the future of epilepsy care has got a lot of things happening. And it's important for us to be in this together as partners. So we've got a lot of going on in genetics, personalized medicine, imaging advancements, telemedicine, self-monitoring, and various other advances where we need to be together. So if we work together, there is a promise of a much, much better future. And I certainly feel that in epilepsy care, we are going to have a huge sea change in the way these patients are taken care of. So I believe that collaboration and cooperation between neurologists and neurosurgeons will lay the level and raise the bar for epilepsy care. So in answering the call for collaboration, we embrace the essence of healthcare, which is to heal, to comfort, and to uplift. So thank you very much for inviting me to be a part of your special day. It was an incredible experience for me. Thank you.
Thank you, ma'am. Now I invite Professor Murugayan for his speech on 3D printing of craniofacial reconstructive implants.
Can I request everybody to sit down so that we can have the talk? Thank you very much for accepting our invitation. Please go ahead.
Yeah. Thank you, Professor Pandey and Professor Vasudevan, for inviting us from across the campus, the other side of the wall. So we've been hearing about the collaborations and what collaboration can bring to serve the humanity. So this is one of the collaborations we always look forward to, and we'll hopefully we'll also break the wall so that we can also work together at ease, and then trying to work towards inventing new things. What is there in front of us? A lot of challenges. So this talk I'm going to give based on the recent work what we have been doing, especially post-COVID. In technical terms and engineering terms, inventions we always call primarily due to the serendipity. So this is also a serendipitous moment. So when in 2019, one of my colleagues in Norway, and we were actually looking forward to have some collaboration with IIT Madras, especially in my group, where they wanted to realize maxillofacial reconstructive implants through 3D printing. So I've been working in the area of 3D printing, which technically we call additive manufacturing, from my Ph.D. days in Delft in Netherlands from 2005. And once I came back to India, so I set up the lab here on 3D printing. So my colleagues who are in Norway in the Nordic Institute of Dental Materials, so they wanted to approach us to have a collaboration, submit a joint call to DST. Believe me, trust me, I mean, I have not heard anything about these terms, what I am presenting here in 2019. So somehow, I wanted to work on a metallurgy, which is my specialization. And they wanted to take care of the medical part of it, and they're also qualifying agents for the medical implants that are to be used in Nordic countries, so Norway, Sweden, Denmark, and Finland. So I had a lot of hope and also belief that whatever we make here, they can test and qualify. And so once it qualified for Scandinavian countries, it's sets a benchmark. So that's how it all started. And when COVID struck, we were all working, in isolations. But anyway, the VCs were there. So then we found immediate use of our research on reconstructive implants, especially the post-COVID mucormycosis patients were requiring these implants. So this is how all started. Quickly, because of time limitations, I'll just take 10 plus 2 minutes only. We can always discuss in further, in that. So anyway, so I'm head of the joining and additive manufacturing laboratory, and we also set up a new additive manufacturing center, IIT Madras, thanks to generous funding from Government of India and under Institute of Eminence grant. So we have a number of 3D printing equipments. So I work primarily on metal additive manufacturing, additive manufacturing of titanium, cobalt, chrome, and various iron-based alloys, nickel-based alloys. So all these, we actually do research. So the outline, before going to outline, I just want to acknowledge all my students. Without them, we cannot do that. I mentioned about the collaboration with Norway, and a few of my colleagues who are also collaborating with us. So one is going to also talk, Professor Saravana Kumar. And of course, we have been interacting with surgeons. Without them, we cannot design these implants. So some of the case studies what I show, we closely work with surgeons so that whatever algorithms we develop for designing the implant would always be requiring inputs from surgeons and fine-tuning. So, and some of the work is also collaborated with the maxillofacial surgeons startup at Zoriax Innovation Lab. Okay, quick outline. I'll skip the introduction to IIT Madras, which you all know. I'll just quickly run through about the 3D printing. Okay, so just basic about 3D printing, the research work, what we do in IIT Madras, and then how we design the implants, the algorithms what we have in IIT Madras from the STL generations and the printing. And before that, I know how the MRI and the CT data is used to design the implant, and then subsequently we can do 3D printing. So some of the case studies what you have done, and then I'll complete this talk. So 3D printing is a colloquial term. So technically we call that as an additive manufacturing. In a conventional manufacturing, if you look at and a component is generally cast and then rolled, subsequently we machine it. So we call that as a formative manufacturing methods. Formative, and then we do subtraction by machining so that we can remove the unwanted parts to get a final object. Whereas in additive manufacturing, we realize the component, layer by layer, directly from its design data. So that means that there is a lot of material saving. We don't waste the material by machining. And also we can create very specific intricate geometries required for the end-use applications. And you see that the additive manufacturing therefore is an unattended process. So starting from the design data and then final component can be realized without any manual intervention. And it's a fully automated process. Directly from digital to physical we achieve without any part specific tooling. You don't need a cast, you don't need a rolling mill, you don't need a lathe to make the final part. And the various names are given for this process, but an academic term is additive manufacturing. And there is a direct connection to welding and joining. And if you look at 3D printing, especially metal additive manufacturing, it's nothing but welding. So if you look at welding torch, what we take to weld, make these chairs, so where the metal is molten and deposited. Same way we are also doing over here. We start with a powder, a laser or electron beam, melts layer by layer. Only thing is in welds we are depositing in millimeters, whereas in here we are actually melting, creating a molten pool from metal in order of 100 microns, for example. The image what you see over here, I'll just take my. So this is the basic of it. So suppose if you want to realize a sphere, first from the design itself we slice it, and then build layer by layer, slice by slice, and one layer or one slice is welded with the previous layer, and so that we can build the entire layer. If you build it, and then we can reconstruct the sphere. There are multiple methods that are available for metal 3D printing, metal additive manufacturing. So one of the methods, what I show in the video here, is known as a laser powder bed fusion. So where we take the feedstock powder, we spread it onto a substrate, and a laser moves along the predetermined path to create a one single layer. So imagine an onion is sliced, each slice, if you bring it together and stick it together, and you create the shape of the onion back. The same, but we are not slicing physically, we are slicing in a computer, using an algorithm. So the design is sliced and we build layer by layer, and then the layers are welded. So that's why we call these as a layer by manufacturing, layer by layer manufacturing. So why this is required, and the advantages in terms of medical implants you all know, but there are tremendous advantages in terms of various engineering applications. So we can achieve large amount of materials and energy saving. So one of these, the part what I show over here, so this is a plunger primary which is used for hand brakes, for a car. And we waste about 70% of the material to make this part. Whereas when you print this component, we can print it without much of material wastage, and we can print number of complex designs, like these are all the other auxetic structures we call it, where if you apply the deformation one direction, it also expands in other directions. It's a negative Poisson ratio, and of course the timely customized healthcare, I will touch upon that later, and also the complex tooling with internal structures, which is impossible to produce by any other method. And this is a forging hammer which we have printed, and these hammers fail because these forging hammers literally are taken to several tons of loads, and we use that to produce a component. And we can introduce a cooling inside the hammers so that it never heats up, and it retains its strength, and it can also enhance the performance of the hammer. And these are some of the applications. So that's what AM we are taking to RRR. So it's not RRR movie. So it's reduce, reuse, and recycle. So that's what we tend to use this metal additive manufacturing, which is going to change how a component is made in the future. It is already changing. And quick slide about what we do. We do number of research on 3D printing in IIT Madras in our center. If you look at, we cover the entire spectrum. We also collaborate extensively with all our collaborators across the globe. I'll just skip this if someone of you want. And primarily, if you look at the last row, the column, and we also work closely with industries on application development, especially with surgeons on processes and reconstructive implants. And of course, aerospace application, we are going to launch a 3D printed rocket. Okay, from IIT Madras. It is printed in one of our labs and tested over there. Very recently, you may see in Sriharikota, it's going to fly. So we are going to take up this technology, and then rocket engine, this entire engine is printed. Okay, first time in the world, and we are going to launch it as well. Okay, and we are printed one, we are going to print a propeller of a Navy ship. Entire propeller is printed. Okay, so there are a lot of advantages. We can talk for hours. I'll just skip this. So we'll go to the actual topic on medical implants. So the medical implants, for this learned audience, I don't need to talk about what are the advantages of IT manufacturing. Is the important advantage. What I see is a no lead time. Okay, suppose an implant is required within a few hours. Once the CT data is available, we have the algorithms now in IIT Madras with the professors Savana Kumars also, and in other the software, and we can realize the design. And once the design is realized, we can print. Okay, as soon as 3 hours. So that's what we are looking at. And the implants what we have already realized, and those are all extremely cheaper because we also identified the feedstock, vendors and medical grade materials manufacturers. We have developed them in the country, one in Bengaluru, one in NCR, National Capital Region, and those the materials are also certified and qualified by us, so that we can readily use those materials and then realize the implant in no time. And it's much lower cost. I see that some of the noble work carried out in VHS to reduce the cost, and doctor also talked about in the morning the cost, how to serve the poor. So we can replace the costly and expensive the imported implants with low cost and best implants made by us, or we can also help in setup if someone wants to set it up the facility. Okay, so we'll quickly run through how we start the work. Okay, so again, all of you know about the CT, the DICOM format. Okay, the file, and this DICOM format file has wealth of information, including whatever extra information is added, are all written in the file, the patient history, and what we use as engineers and technocrats. So we look at the image part of it, image analysis. So these DICOM format also carry the contrast in terms of the design, the hidden design information. So each pixel carry the information in terms of the boundaries between what can be a tissue part of it, what can be a bone part of it. So the work start is looking at the the DICOM file in characterizing the actual the anatomy part of it or tissue part of it. So using a grayscale mapping, we can identify again by declaring which grayscale refers to the part of the tissue part or the other bone part, and that requires a careful image analysis algorithm. Okay, so we can define a grayscale with respect to the what part goes in there. So once that algorithm is running to the DICOM format, we can construct the boundaries of what can be tissue, what can be anatomy. So that is the first part of it. So, and why do you need to do that? Because the DICOM format cannot be readily used for printing, because the printing requires a computer-aided design format. Okay, because we are going to further manipulate that for slicing, and then construct the laser paths from those slice data, the contour data, and that should be given for the printer to print the part. Okay, so we'll start with the first the segmentation from the image analysis, and this segmentation is carried out to separate the contrast-based contour generation. So once the contrast is identified by either automated algorithm or in complex cases we also semi-automated with the manual intervention, and then we do the segmentation, and the region of interest is identified. So this I show is one of the maxillofacial reconstructive implant, the work what we are trying to get, and this is a black fungus infected patients for reconstruction. So once the segmentation is done and we know the boundary, the contour, and the actual area of interest is generated, and then those area information is converted into what is known as a surface filled with triangles. And that is what is known as an STL file. STL file is this commercial name. It is given as stereolithography language file. and that contains the information about the contour of the shape. In a 3D printing, you don't need the volume information. You need the surface information because we are going to create the part, okay? So only based on the contours, the outside, the surface. So we create from the actual segmentation, the generation, the area of interest, and then using a simple conversion, we fill the surface using triangles, and then subsequently we can create what is known as the .stl format. And this is the input for the 3D printing. Okay, so, and this is a reconstructed image from DICOM data, where we get a three-dimensional surface information of the entire skull is reconstructed over here. And from that, next is to design the implant. So that again, I'll come back to that. And similar exercise also is carried out for cranial implants with Professor Sarana Kumar's work. Here's the algorithm, the reconstructing using the same principle from the cranial MRI data, using the segmentation algorithms, what we are actually working for facial here, and probably can also discuss. And then we identify the contours. So once the contour is designed, okay, so we can reconstruct the actual implants required. So again, this is an automated system, but again, we need the manual interventions to create the design. And this is one of the other cases of the implants designed by us in our lab, where a 12-year-old girl required femoral implants. And again, the same algorithm was used to design. And there are a lot of complexities because there is no data, and that the girl was suffering from a very rare form of cancer. So we had to use the other leg's data to do the reciprocal of it, and then subsequently design the implant. And then these are the implants what we printed in our lab using cobalt chrome. And we also made it as a modular implants, and so that on the table, if the implant length is not sufficient. These are all what we understand from the surgeons, on a radiation oncologist, may also require, the implant design must be different. So we made it as modular, where the length can be extended on the table, on the theater itself. So these are some of the advantages of, again, 3D printing, what you get, make it modular, extremely patient specific. You may see all these, the design part, what we introduce for stitches, etc. Okay, so quickly, and the black fungus, the work, what we have been working on that. Again, I always call that, this is an extremely serendipitous moment. In 2019, I was not even aware COVID is going to strike, but we were working on developing this algorithm on reconstructive, implants, so that, in some point in time, we may use that, but within 1 year, we had to use this. So the work was already done in our lab in realizing those things. The moment, some of my surgeon friends came to us, we need such implant because number of cases, what they were facing, what they are getting, tremendous due to the mucormycosis infection. And this data is alarming. It's still, we have been working with number of cases, and close to 60,000 patients what we understand require these reconstructive implants. I'll quickly just in view of time. So these implants also extremely difficult to design because the part of the facial structure is completely missing. It's not like an off-the-shelf item. Each patient requires the unique implants. So once the reconstruct generation of STL file is done from the DICOM format, we have to arrive at number of possible designs of the reconstruction implants. So for example, these patients, again, this input of surgeon is extremely important, where exactly we want to introduce the actual the screws and the type of implants. Some cases, the actual fitment and also the contour of the face can also be different. So if you look at these complexities on the design, it is not on a two-dimensional data point we manipulate. We need to manipulate in three-dimensional data space, including the curvatures, the surface, okay, and the thickness, the number of weight reduction strategies what you'll have to follow. For example, here we have to reduce the weight so that the implant have a better osseointegration, for example. So therefore, so again, it cannot be fully automated. The design of the implants from the STL conversion until the final design requires extreme collaboration with surgeons, because the input comes from you, where exactly these fitments should reside. So we sit in each case 1-to-1, okay, and for 30 minutes, and we decide from basic approaches. The one case study, then I'll wind up. Okay, so this is one of the very unique cases where the patient lost the majority of the facial structure. And this case came to us, again, serendipitous moment. I was giving a talk in Hyderabad. One of the audience who was a professor in one of the colleges in Hyderabad, and he came to me, my uncle is suffering, and they lost entire wealth. They sold a house to keep him alive, about 45 lakhs. They spent already. And then he came to us, can you help my uncle? So we brought him here, and we did the entire exercise. He was living without anything, no teeth, he could not eat whatsoever. And we brought him here, and again we carried out, and if you look at the number of implants, what you have to put him to get these prostheses made. And we could do that, and then we carried out the surgery. This is not surgical photo from my friends who are there. And these implants are printed in our lab. And we could give him life back, this face back, smile back, and he could eat now. And the other important aspect is these the patient-specific implants would also make them recover faster. Within a month, they could eat. So that is the major benefit what we have in these 3D printed implants. These are titanium implants. So these are number of implants what you have already were printed, and then it went to the surgical. You see that each implant is very unique. These are not off-the-shelf item. And we could do that in collaboration with surgeons, and then we arrive at the design, and we print, and again, and give. It's extremely unique implants. So a few cases we also done on accidental trauma cases. These are also very, you know more than me, on the timely intervention, the implants required. Again, the same algorithms can be used to arrive at the first design, and then subsequently we are we are ready to go for generating the implant. And some of the tumor implants I'll just skip. Okay. And you have time. I just wanted to say one thing. Again, the collaboration is the key here. And we are working independently on the developing 3D printing technology for titanium and cobalt chrome. We have the expertise and world-class facilities, but then the use comes from the user, right? And then by collaborating, we can alleviate the pain of people. And especially, again, doctor was talking about indigenization. And we can do it here because best brains are already here. And why do we have to go elsewhere? On getting the implants back, and then implants may fail. But here we know what we are doing, and we could do, and we can also improve, right? So that's what I wanted to convey. Also, I acknowledge the funding for this work from DST and Ministry of Education. Thank you. Thank you for your kind attention.
Thank you, sir, for telling us about your expertise. The upcoming speakers kindly stick to the time. I request Professor Sarvanakumar for his speech.
A very good afternoon to everyone, and thanks to VHS for inviting me to this august audience. And as Professor Muru Gayan introduced about the patient-specific implants and 3D printing, so I thought I would talk about some techniques, particularly in modeling and simulation, that could be used for understanding various surgical outcomes. So I am with the Department of Engineering Design, and I am part of this IOE Center on 3D printing, and we do a lot of these patient-specific implants. So I started actually to work with a spine surgeon in CMC way back, and we started intervening with 3D printing for surgical pre-planning, like in this case you see a scoliotic spine, and we started with polymeric printing even before we had this metal 3D printer somewhere a couple of years back. And this is one case that I am showing that I did with Dr. Raju from MMC. So we started to also think, can we develop models to understand the spine biomechanics so that we can predict or make some decisions to do the surgical corrections. So I started to work on developing these kind of models, and to start with, we started to work on the cervical spine. And I think this slide I will skip, but the major motivation was that if we have to take patient-specific care, a lot of these modeling exercise has been done a priori, but these models are representative model, something like, okay, a 50th percentile male model. Okay, I have a finite element model, it will give me some biomechanics, some responses, but how do I do this simulation to understand if I have to take it to some patient specific care or understand how the morphological variations will affect. So we started to work with model development, which was first of its kind, wherein this morphology of the spine can be inbuilt. That means while developing the model, I can change these dimensions, I can parameterize. So this was one of the first exercises, and we came up with first a cervical spine model. So this is the C2 to T1 model that you are showing, a glimpse of that, which has all the details of the the structure, the anatomy. I can modify the geometry of this. I can change the material properties of this so that I can create patient-specific models if that is required. So these are the details of this, and we go step by step, like first developing one FSU, checking, validating it, verifying it, and then extending it to the entire spine. You check the ROM responses with the cadaveric experimental data that is available, and then once this has been done, we extended this to morph this to different scenarios. Like you can change the various angles, facet angles, or maybe the vertebral height, or the orientation, the depth, and so forth. And we have to also ensure that numerically it is stable, because when we do this morphing, I had developed the 50th percentile model and it was running in my computer, but suddenly when I morph it, right, it may fail to run. So we also try to understand whether within the expected ranges of variation will these models run, or some manual intervention may be required. And we did see that very few cases, like 2%, there may be some critical issues, but otherwise these models we were able to morph. So finally what we got is a model which could be morphed, which is validated, both we say verification and validation. So verification essentially involves that when I numerically it is stable and it is able to give the results, and validation is based on the actual responses that is experimentally characterized based on some cadaveric experiments. And so you can see here the morphing operation, like you can change various parameters associated with this, but I am just showing as an animation, like you can change the vertebral orientation or the facet slopes, or you can change the vertebral depth, vertebral size. So it is possible now to quickly customize, because you can see that the development of this model itself, the first initial model development has taken us about 2 years time. So that means for each patient, if I have to start working on it, cannot happen, it will not be realistic. But this kind of a morphing based model, first of its kind, can be quickly morphed to a patient specific data. And here you see like different responses for different types of models. Say some are more lordotic or kyphotic, or you change the different dimensions. So you can see each of these lines are talking about the responses and how it is, the sensitivity of that, all of that we have studied. So once we were confident about this model, we started to work a couple of problems. One problem that we worked was with the professor in CMC. This was on the corpectomy, and we wanted to understand what happens to the outcomes if the spine, the curvature is different. So from lordosis to, let us say, more kyphotic, if it happens, what will be the outcome? Or when he is doing an instrumentation, because the final settlement, if it is different, what is happening to the ROM, how is the adjacent segment ROM is changing, and corroborate with the clinical outcomes like the adjacent segment disease and so forth. And we were able to give a predictive understanding, because these kind of models can then be used to say what kind of outcomes one can expect even before we go and do the operation. So here are some studies on the corpectomy results at certain level, and how the change in the kyphosis is affecting the outcomes, the change in the ROM and so forth. This is another use case of the developed model. What you see is a neck whiplash injury scenario, and we were studying whether based on the occupants, because most of the times these automotive companies which have developed various protective systems, right from your seat belt to other systems, they are made for, let us say, 50th percentile male. But you can think that the occupant or the driver could be obese, or he could be an old person, or he could be a female. So all these variations, how is it causing, let us say, the susceptibility to injury? Because that can change, because the head mass will change, its properties like center of moment will change, the properties of this neck will change, the sizes will change. So the injury susceptibility of a female driver is not same as that of a male driver. And such a model and such a simulation can help in devising better, safety systems in the automotive. So this is another use case. And here what you see is the response for a rear impact, which is typically the case where you have this whiplash injury, because it is like an inverted pendulum, and it undergoes abnormal the S type of curving, which can cause injuries. And here you see the responses, and that we try to study based on parametric study, how by different changes like the head mass or the center, how it is affecting, and thereby trying to see the injury susceptibility for different types of people who might be riding. So this again the same thing like for different types. So you can see here, like I have now 80 simulations. Each of those lines are 80 simulations. It would have never been possible unless I would have had that morphological model. Basically 80 individual models have been run. So it is now possible that if I have a patient specific data, it is possible for me to quickly develop this kind of a model. So from this experience, in fact, now we are going ahead to develop customizable morphological model for the lumbar spine, and hopefully as my next venture into this, I would be able to develop also for the thoracic spine, where probably for a lot of the scoliosis and other applications it can be done. So yeah, to quickly summarize, so we have developed a modeling approach to develop patient-specific spine models. We started to work with the cervical spine. Now we are working in the lumbar spine. We have a validated model for that as well. And we have done some use cases, both clinical as well as in the area of automotive simulations. So I would like to thank my collaborators, a couple of the doctors and surgeons who are part of this study. And thank you again. Thank you to VHS, and hopefully we would be able to collaborate and do a lot more to the patient-specific care. Thank you. Hopefully, hopefully I saved you some time. Thank you, and I'm here if you have some questions, I can take.
Thank you, sir. That was very informative. Now I request Dr. Rahul Srinivasan for his talk on neuronavigation in spine.
Screen. My talk is the last. I thank Dr. Vasudevan and Dr. Anil Pandey for mentoring me and giving this opportunity to speak about neuronavigation in spine surgery. So, it's not working. It's not moving. So that was a technical glitch. We faced the same problem during navigation also. So I start with this. This International Journal of Spine Surgery, they had prepared a questionnaire among spine surgeons, neurosurgeons as well as orthopedic surgeons. They had all these 5 questions in place, and the results of that was most of them had only superficial experience. And you see this. Only 25% they were using some kind of neuronavigation, and 2% were using it on regular basis. This is among just 147 the doctor surgeons. So what was the problem? Because there was an increased cost involved in navigation, the increased OR time, as well as there's a lack of necessity. At times the surgeon feels I can finish quickly with C-arm, and then there were too many glitches while doing those registration and doing it in the real world. So I'll go with this agenda today. So navigation has its principle from cranial frame-based stereotaxy. So it's almost now 3 decades. There's a snail progress in navigation. Of late, it is progressing very fast with the help of AI as well as virtual reality. So you can see the Medtronic was first to start with this point-based system, that is in 1992, and later on other companies followed it. So we all started with this 2D based C-arm, where you can see we get the sagittal view as well as the AP view. It should be a single, so this superior end plate as well as the pedicle should be single. That's what Dr. J.S. has demonstrated yesterday in his surgery. So we are all familiar with this, and it is ergonomically, it's easily, you can move in and out of your OR. But the disadvantage when it comes to doing this is, when you are using this in a minimally invasive surgery, spine surgery, it's a keyhole technique. One thing is you don't have any axial view. You just have a sagittal as well as coronal plane to instrument the patient. So the lack of axial view is just your imaginary anatomical knowledge. So problem is that, and second is a lot of radiation is been involved, not only to the patient, to the OR personnel also. So this is how the generation has evolved. So the first generation was we get a preoperative CT, we take the patient, this preoperative CT was taken in a supine position, we take them to OR, then we prone them up, and then we register them, So during this process, there's always an intersegmental change occurring while positioning the patient. So always there's a inaccuracy dealt with that. So we had lot of inaccuracy and lot of the system actually had failed. So the second generation, they started with doing intraoperative CT or 2D CM, where they included CM to give the inputs in the patient in position, when patient is being positioned on table, and the clue has been given to the navigation system, and then it has been instrumented. So that was the second generation system. And the advantage of this is you need not do auto registration with this. What you mean by registration is you are matching the real world image, the MRI image with the, or CT image with the virtual image. So in this case, in the second generation and the third generation, you have no need of doing those registration. It's a auto registration. So accuracy is still more better with that. And moreover, there is all these implants are, you can instrument with the navigation probes, and it can easily fit into the system. So this is how they are classified into 2D, 3D, intraoperative and preoperative. Preoperative. This was the first generation, and this all was the second and the third generation. And the fourth generation has been contributed by the robotics and the AR/VR. So this was the first generation of the stealth. You can see a optical, this one, infrared, this is the infrared emitter, IR emitter, and this is the this is the scanner which takes the inputs from the instruments, and you can see the, this is a dynamic reference frame which is attached to the patient's own spine. So navigation is all about like GPS in the OR. You have something called as this optical emitter, infrared emitter, which acts like a satellite, and you have the passive as well as a dynamic array, which is not, it's like your car or your mobile, and the application is nothing but your GPS. So basic outflow is, first is image acquisition, whether it can be pre-op or post-op or intra-op, or then there is a type of navigation involved, whether you are using optical, the infrared one, or the EM one, electromagnetic one. Then there is a dynamic, the reference array, and the registration which I talked about. So basically the inaccuracy is all about this fixing of this dynamic reference frame perfectly on the patient, and it should not move throughout the procedure. And second is the registration. If it is automatic, the level of inaccuracy is reduced. So these are all different companies, they have their own range of equipments. This can emit infrared, and that can be captured by the optical camera, and you have a variety of gadgets. So this is the regular optical infrared system where this is the clamp which will be attached to the patient's spinous process, and this has to be rigidly fixed. And this is the dynamic reference array which contains the sphere which reflects the infrared which is emitted by this system. And this is the sensor which captures that the reflection of this rays. So this creates a line of sight view, and there should be no disturbance between this line of sight. So then we moved with 2D CM navigation, where our own CM is been, you have this frame which has been installed in the drum of the CM, and that contains lot of fiducials, and this clue has been used for auto registration with the navigation system, and then we navigate on the spine to do the surgery. And you can see this, this one is from the Zyme company. You can have this 3D CM which rotates almost around 180 to 190 degree around the patient to get the image first, and that the image has been transferred to the stealth station, that's the navigation system, and then we operate on them and put the implants, and later on we can intraoperatively we can check the position of the screw. We can do one more scan to check whether the screws are in place or not. So advantage of doing this is you have the axial plane also, which I described, which is a disadvantage of the 2D system, and the post-op imaging can be done at the table itself before moving the patient out of the OR. So this was my previous institute where I used to work. So we had this 3D CM, and this is the Medtronic system. So the inputs will be given from this to this, and then we can correct all this complex deformity. using this inputs. So as I told you, the auto registration is best and the need of axial plane is best. So this is just the classification of from the first generation to the last generation. So what are the indication basically? So you do minimally invasive surgery, you might require it. Deformity correction, absolutely yes. They will have dysplastic pedicles, rotated pedicles. It's difficult to instrument them. Fusion procedure, yes. A lot of implant has been involved in that. The craniovertebral junction fixation also, yes. And the bony tumors. Now, why this is important is because there is a certain concerns with the navigation system because of instrumenting intraop. You will have this wobbling movement whenever you put the screw in. So that how can that be avoided? Because that can produce an artifact and an error of accuracy also. So you can actually use an electric screwdriver to put the screws. You can plan the trajectory you can plan the trajectory before itself putting the screw. So this can avoid this wobbling related inaccuracies. The distance from the array, the dynamic reference frame, if it is far off from the optical sensor, the level of inaccuracy is actually little less. So accuracy is actually inversely proportional to the distance. So that is why it should be as close as possible to the camera system. And next is the cost effectiveness. So if you use it routinely, I don't feel there is a decrease in this problem you will encounter. You have to use in simple cases and complex cases to achieve this cost effectiveness of the instrument. And there's always a learning curve. It's not only for all the OR personnel should also be equally responsible to learn this stuff because it is not one man. And then radiation associated, that is very, very important because the radiation associated is only to the patient when we use the navigation system. It is very less to the OR staff and the surgeon ourselves. So these are the disadvantages of the navigation: long operating time, and then tedious, too expensive, all those things which I have dealt with. The advantages are you can use in any kind of surgeries, even in dysplastic and deformed pedicles. So see, the one article I have found very interesting in this JNS is the medico-legal impact if you have a misplaced screw. You can see the amount of this payout awarded to the the plaintiff. So when the root injury has occurred, this is only because they have used 2D X-rays. So you can get into a sue if you don't use a navigation there. So to avoid this, better is to use navigation. What about the accuracy then? As compared to any kind of 2D fluoroscopy, the navigation has far greater accuracy, and it's almost like the as low as 1 to 5% of the pedicle perforation. So this grading has been given from Rajshekaran et al. From the Ganga Hospital spine team. So where navigation comes very useful is in the type 4 and type 5, where it is not safe enough to put a screw. It is just correct. So when you use the navigation, you can exactly put your implant inside without having a perforation. So now my fellowship experience with at CMC Vellore, we have used this OARM system in 11 patients. Between 2022 and 23, we just saw what were the pitfalls and advantages. And the workflow was intraoperative. We used to scan them intraop, and that input has been transferred to the navigation, and then we navigate on them. And so the tracker, before discussing that, the tracker has to be fixed perfectly. It depends upon what surgery you do. If you do a transoral odontoctomy, the tracker has to be next to the Mayfield. It has to be fixed to the Mayfield. And if you do cervical, thoracic, lumbosacral, the region of interest, it should be as close to the region of interest. So you can see the real time, you can see the coronal view, the sagittal view as well as the axial view. In fact, you can actually project and count the millimeter of the pedicle as well as the axial length of the screw put. So out of this results of 11 patients, we had only more than 2 mm, we had 2 breaches. Now why we had that 2 breaches is because we didn't navigate correctly on the implant. Every time when you put a screw, you have to again check with the dynamic reference frame. If you don't check with the dynamic reference frame, you can lead to pedicle perforation. So this is one of the case which ankylosing spondylosis chalk-stick fracture. We had a long construct. In this case, it's very useful because we don't know the actual anatomy from the posterior surgical part. We actually have less of anatomy. So in those cases, it was helpful. And about this cases, we have 3-level T-lift going on, the implant going on. And then there was a 4th generation with including robotics. We had Razor, Rosa as well as Globus system which we included. And the robotic system helped us in further achieving greater accuracy. So this is one Globus system which I just wanted to show you video. It actually aligns itself to the surgical pathway and screw can be put easily. Yeah, I'll finish it. 2-3 slides only. So overall the robotics as they have performed very well. Their almost accuracy is more than 95%. And what is coming next is augmented and virtual navigation. You can actually, you have a head mounted thing which has head mounted thing which can actually display real virtual image of the spine and you can directly put the screws. Accuracy is almost 100%. So I'm skipping this. So latest is the navigation techniques in endoscopic spine where they have used EM to guide the single needle to achieve this accuracy. And these are all the available things, navigation system in the industries. So thank you. So you should actually know the anatomy. Without knowing the anatomy, even if you give this tool to a fool, he is still a fool. Thank you.
Thank you, sir. That was very elaborative. Now, I request Dr. Ravi Ramurthy to facilitate Dr. PRITHIKA CHARY. I request Dr. Kuntal to come on the stage, please. I'd request Dr. U.S. Srinivasan sir to come on the stage, please. Dr. Jayesh sir to come on the stage, please. I'd request Dr. Murli Mohan to come on the stage, please. Sir, I'd request Dr. Soman to come on the stage, please. Now I request Dr. Suresh to come and facilitate our IIT faculties. Professor Murugayan, sir, please do come on the stage, please. Oh, sir. Now I request Professor Sarvana Kumar to come on the stage, please. Okay. So I request Dr. M.C. Vasudevan to facilitate Dr. Suresh. I'd request Ms. Joshita to come on the stage, please. Come. Now I'd request Dr. Rahul to come on the stage, please. I'd request Dr. Anil Jackson to come on the stage, please. I'd request Dr. Akila to come on the stage, please. I'd request Dr. Mangal to
I asked Dr. Divya to come on stage.
Thanks.
Feeling gratitude and not expressing it is like wrapping a present and not giving it. I deem it a great privilege to propose the vote of thanks on this memorable occasion. It is a great honor and deep gratitude to Dr. PRITHIKA CHARY to accept to be the orator of our 26th ALNC Oration. I thank IIT faculties, Professor Murugayan and Professor Sarvana Kumar, for their help in holding a landmark and pioneering microneurosurgical workshop, a journey which started 30 years ago. To begin, on behalf of PGNS ALNC, I express my greatest gratitude and appreciation to VHS Honorary Secretary Dr. Suresh Director Dr. Gupta, CFO Mr. CHARY, and all other admin staff. A profound thanks to our visiting faculties, Dr. U.S. Srinivasan, Dr. Kuntal Kanti, and to Dr. Jayesh Sardara for teaching us the delicate nuances in neurosurgery, sparing us time from their busy schedule. My heartfelt thanks to theatre nurses, workers, anesthesiologists, anesthetic technicians, neuromonitoring team, neuronavigation team, and various sponsors. A sincere thanks to Dr. Professor Mohan Kameshwaran and MERF team for their timely support. A special thanks to Dr. Ravi Ramurthy and Dr. Murli Mohan. Our thanks goes to our catering and coffee services for being the constant source of energy. Last but not least, I thank the ALNC residents, staffs, and audiovisual team for running the show efficiently. Please do join us for the lunch.